banner of Women in Nephrology, which is along with the Indian Society of Nephrology also. It's a new group which has been initiated to focus on problems in women, the kidney diseases in women. And I'm happy to inform patron Dr. Anuradha is a part of this discussion today as well. And today it's an auspicious day for us because it's World Kidney Day as well. World Kidney Day is soon to come, 10. We are celebrating this as a part of World Kidney Day celebrations. We are having 1 week long celebrations. And incidentally, today happens to be the Women's Day as well. And this program is being organized by the WIN Group. So we have 4 lectures. And the main purpose of this program is to have a dialogue between the physicians, the general practitioners, and the nephrologists. All of us should work as a team. And I'm so happy and honored that we have extremely senior, very influential, very academic panel members from IME, from API, from RSSBI, from Endocrine Society of India, and from the Society of Nephrology. So, and also in addition, we have Dr. Anuj, who is he is the leader for the Indian chapter for American College of Physicians. So it's a unique opportunity that all of us are there on this platform. And I'm really thankful to all of them who have agreed so readily in this era of so many webinars and seminars. I know it is difficult for many of the senior members to join, but it's the passion for spreading knowledge and improving the awareness about kidney disease that everybody has readily agreed. So really, my heartfelt thanks to all of you. So without any further ado, I'll start with the first presentation. As I said, we have 4 presentations followed by panel discussion in which we'll be discussing some of the important pertinent questions put to us by GPs regarding that topic. So I'll start my presentation. As I said, I'll be talking about the screening part, the screening of chronic kidney disease. I'm Dr. Manisha. I'm professor and head of Department of Nephrology at Osmania Medical College, Hyderabad. And I'm a proud student of Dr. Anuradha and Dr. Girish Narayan. Both of them are today on the panel. And I've always been learning from all of you. So as I said, happy occasion for us, the Women's Day as well as the World Kidney Day. We are having this World Kidney Day since almost 15 years now to focus on various aspects of kidney disease, because kidney disease, as we all agree, has become an epidemic of sorts. And the World Kidney Day is celebrated on the 2nd Thursday of March every year. So unlike Women's Day, which always falls on 8th March, we have World Kidney Day, which falls on 2nd Thursday of March every year. And every year we have a theme. And this year, the theme is, as you can see there, kidney health for all. And the focus is to bridge the knowledge gap for betterment of kidney care. So with this in mind, I'll be talking about the basics of screening for CKD, what everybody, even an MBBS person, should know. My talk is not going to be hi-fi, but I'll focus on the practical points. So the WHO screening principles, they say that for it to be a public health problem, there should be certain features. The problem should be a public health problem where screening is universally required. So WHO recommends screening for only certain diseases. And these are the 5 criteria of those diseases. That disease should be a public health problem. The disease should have a long asymptomatic period. The screening test should be available and should be cheap. And the treatment to arrest the progression should be available. And the treatment should be cost beneficial. So let us see whether CKD fits here. CKD, is it a public health problem? Till now, we knew about diabetes, we knew about hypertension, we also knew about cardiovascular disease. Even the public knew about these diseases. But unfortunately, CKD, nobody had any idea, especially the public. They don't even know where the kidneys are. And do we think it's a public health problem? Does it affect a significant proportion of population? Does it have a huge cost? Let us see. So chronic kidney disease is a global killer in plain sight. Nobody recognizes it. Do you know how common it is? It affects around 1 in 10 individuals across the globe, 1 in 10, 10% of the population. And in India, one study by Dr. Ajay Singh has shown 17%. So we know that diabetes and hypertension roughly around 20%, 25, 30%. CKD is not far behind. It's 17%. That's a huge number in our country. 1 in 8 Indians has chronic kidney disease. It's frightening, in fact. And what are the causes of chronic kidney disease in India? So I'm proud to say that we have this Indian CKD study, which is our own study. We were also contributors in this study, which got published in the leading international journal, Kidney International Journal, where we have a cohort of around 5,000 patients. And you can see that in our country, as in the West now, the commonest cause is diabetic kidney disease, 25%. Then chronic interstitial nephritis. This is becoming very common, 24%. Then unknown cause. This is again scary, maybe because of herbal medicines or what, we don't know. Indigenous drugs, pesticides, we don't know. It's unknown, CKDU. And then chronic glomerulonephritis as 7% in our study. So this was our own study recently published, and you can see that CKD mainly is because of diabetes. And is it affecting a significant proportion of population? Just look at the slide. There's a 90% increase in incidence, almost 89% from year 1990 to 2016. So last 25 years, there's a jump of almost 90% in incidence, 90% in prevalence, and 98% increase in deaths because of chronic kidney disease. Really scary. And does it affect the patient's life? Yes, it does, because treatment is available. We have 12,881 dialysis stations in India. Then National Dialysis Program was launched, which aims to provide 8 stations of dialysis in 688 districts of India. But do you understand that we need to dialyze how many patients per year? 2 lakh new patients of end-stage kidney disease are diagnosed every year. Not even CKD, end-stage kidney disease, 2 lakh per year. And with all these machines in place, how many are we going to dialyze? We'll be able to dialyze only 50,000 new patients. So what happens to the remaining patients? 1.5 lakh patients, we are not able to do anything. Whatever patients we provide dialysis, dialysis is costly. Either the patient pays or the state pays. Each dialysis session roughly is around 2,000 per week, per session, 3 dialysis sessions per week. Each session is 4 hours long. And this procedure continues lifelong till either the patient dies or undergoes a transplant. Each dialysis requires around 150 liters of water. And if you were to do peritoneal dialysis, the cost is again 30,000 bucks a month. So dialysis is available, but very costly. Transplant is also available. Transplant roughly 5 to 10 lakhs. And even after transplant, the patient has to take medicines, 10,000 rupees per month, lifelong. So as I said, 2 lakh people with end-stage kidney disease every year. So India would be needing 2 lakh transplants per year. And how many are we doing? 12,000 to 15,000 transplants per year happen in India. What about the rest of people? So it's very difficult to match the increasing burden of chronic kidney disease. So definitely, ladies and gentlemen, CKD is becoming a public health problem where the numbers are huge, the cost implications are huge, and it's affecting the life of the people. It fits the bill of being called a public health problem. The second important thing was, should we screen? If there is an asymptomatic period, yes, screening is required. So does CKD fit this bill? Yes, chronic kidney disease can be asymptomatic. We won't be able to diagnose it in the early stages. Hence, screening is essential. So we know that symptoms of kidney disease, we all know decreased urine output, swelling of feet. But remember, these occur in the stage 5, the last stage of chronic kidney disease. In stage 3 and 4, you may have symptoms. Sometimes they may not be related to the kidney. The patient does not identify them with a kidney disease, nor the general practitioner sometimes. The patient may present with anemia because erythropoietin production occurs in the kidney, may present with fractures because vitamin D, active vitamin D gets formed in the kidney. With young hypertension, sometimes the patient is treated with BP drugs, but the creatinine and urine protein is never checked. So kidney has multiple functions apart from removal of toxins and water. And as a result, patients may present in different ways. And many of the times they get unrecognized. They go under-recognized. As you can see, CKD can present with any system abnormality. Urine output may be good till the last stages of CKD. Even an end-stage kidney disease patient may have a good urine output. And that's why it's often missed. And what about the first 2 stages? They may be completely asymptomatic. So does it have a long asymptomatic period? Yes, many of the times the kidneys get damaged, keep on getting damaged inside, but there are no symptoms. And hence it's important to screen. Otherwise, how will you pick the stages 1 and 2? You cannot. Fine, so we have realized that it's a huge public health problem. And screening is definitely required because we have a large asymptomatic period and sometimes we can't even identify it because it presents with different symptoms not pertaining to kidney. The third point is, okay, it needs screening, we have agreed. But is it possible? Are the tests available for screening? So toolkit for CKD screening has been advanced by International Society of Nephrology as well as by Indian Society of Nephrology. And what tests toolkit is? Only simple 2 tests, urine albumin and you have creatinine. With creatinine, you calculate the eGFR. That's it, 2 only, not ultrasound, nothing else. These 2 are the screening tests for chronic kidney disease. Urine albumin, we all know that normal is less than 30 milligram per day or less than 30 milligram per gram of creatinine. More than 300 milligram per day comes as severe and between 30 to 300 is moderate. Okay, easy. We can get it done in any laboratory. Important is when we are getting this done, we should not test if the patient has fever, has urinary infections, in a pregnant patient, uncontrolled sugars or congestive heart failure. And only one reading is not enough. We have to demonstrate that it is persistent for 6 months by doing at least 3 samples. And 2 out of these 3 samples should be positive. So understood. First screening test is urine albumin. But many of the government laboratories do not have albumin creatinine ratio. So can we do a urine protein? So yes, you have a risk calculator. It's available online, ckdpcrisk.org, where you can just fill the protein and you can automatically get the albumin. So this also can be done. So either you can measure the albumin or you can measure the urine protein. So that's important. First screening test is urine albumin or protein. The second important test is creatinine. And we all know that all smartphones, you can download this app from the NKF Foundation. It's available, easy, free download. And you can just fill the patient's creatinine value, age, gender, and race, and you automatically get the eGFR value. Most of us use the CKD epicreatinine, the top one infection equation for adults, and the last one is for children less than 18 years. So easy. This should be done by everyone, GPs, MBBS, PHCs, everyone. So your prescription should have a report of urine albumin and also a creatinine with the GFR mentioned, and which can be easily seen from the smartphone. Nowadays, there is some talk about cystatin C. Cystatin C is costly. It's around 1,000 rupees in our country. But in some confusion cases, this can be used. So I'm not advocating this should be done for all. Cystatin C, 2 advantages are there. First thing is it doesn't depend on the race. The second, and it can be easily again used to give GFR. So you can see the third equation here. You just put the value and you get the GFR. The advantage of doing cystatin C is that it does not vary with the race. The second important point is sometimes with the CKD epi equation using creatinine, we may overdiagnose CKD. So those patients where the GFR comes between 45 to 59, we can do the cystatin C GFR. And if the cystatin C GFR is more than 60, then we don't call it CKD. If it is less than 60, then CKD is confirmed. So this is a minor point. Those who want to do advanced testing can do this. Otherwise, creatinine GFR and urine albumin is enough. And once we have done the GFR, which is on the left side, and once we have done the albumin, which is on the right side, we can classify the patient depending on the level of protein and the GFR. So very simple. So in our prescription, we should write CKD stage G2, A3, depending on whatever the GFR and creatinine is. And this should be on the prescription of any MBBS doctor, not only the physicians, not only the nephrologists. So fine. So we have decided that screening is important. Only 2 tests for screening, albumin, creatinine, and do a GFR, finished. But whom to screen? Shall we screen the population of India? In many of the countries, universal screening is done, but not in India because we do a targeted screening to save the cost. And it has come on the cover of Times magazine, which patients should be screened: hypertensives, diabetics, and those with a heart problem. These 3 are the major indications for screening. And if you look around you in your clinic, many of the patients would be having these problems. So just think, have you screened them? Does your prescription have albumin, creatinine, and GFR on it? What are the other groups which should be screened? Older age, race, especially the black race, SLE, HIV, those with family history, genetic risk factors, low socioeconomic status, those with environmental exposures, for example, those who spray pesticides, etc., those with a history of prior AKI, those women who had preeclampsia in the past, Those with history of nephrotoxin abuse, for example, some of them may be on long-time painkillers and obesity. So these are the other categories of patients where we need to screen. So predominantly 3: diabetes, hypertension, cardiovascular disease, and these are the remaining ones. So this you should remember whenever you see a patient. Does he or she fit into these categories? If they fit, do a urine albumin, do a creatinine. Fine. Who should do the screening? Should a nephrologist do the screening? So remember, for a 1.3 billion population, how many nephrologists we have? 2,000 plus. How many physicians are there? 10 lakhs, including physicians, GPs, MBBS doctors. This is from that article mentioned below. And how many Ayush workers we have? Ayush doctors, 7 lakhs. So if we have to screen the 1.2 billion population, those of whom have risk factors, then we have to take the help of the entire team. Only nephrologists are not going to be sufficient, neither are the physicians. The general practitioners have to join the bandwagon, as well as the Ayush workers. That's why we talk about continuum of care. You can see the stage 1, 2, and 3 should be handled by not the nephrologist, primary care physician, who may be anyone. And as the stage increases beyond 3, 4, 5, the patient should be handled by the nephrologist. So it should be a teamwork. And here you can realize we want to pick up CKD in stage 1, 2, and 3. What happens is by the time the patient reaches the nephrologist, he's already in stage 4 and 5. At that point of time, we have to only manage end-stage kidney disease. We cannot reverse it. Who has the power to reverse it? Who has the tools to reverse it? Where do the patients of stage 1, 2, and 3 go? They go to the general practitioner or physician, or maybe primary care physician. So they are the persons who have to think about it and screen these patients. And if we screen, what do we do? Albumin is positive, protein is high, and creatinine is high, GFR is low. What do we do? Because we can have some treatment to retard the progression of kidney disease. We all know about it, but we should think whether we have covered all that treatment. The treatment varies with the stage of CKD 1, 2, 3, 4, and 5. What is the treatment? First thing is physical activity. This should be on your prescription. We know it, but do we write it on the prescription? Most of us don't. 30-minute walk per day. Diet. Dr. Umesh would be talking about. This also should be on our prescription. Smoking cessation should be mentioned on the prescription. Glycemic control mentioned on the prescription. Target 6.5 to 8, individualized. BP control, ideally 120/80. Nephroprotection, there should be ACE inhibitor or ARB on your prescription, or SGLT2 inhibitor can be added to RAS blockade. And we all know after DAPA-CKD trial that it can be used in non-diabetic CKD as well. They are the molecules of the decade. Then statin, this is often missed. So remember, statin in CKD, we are not using for dyslipidemia. We are using for reducing the CV risk. So all diabetic CKD patients, right from the age of 18 years and above, even if the lipid is normal, statin should be a part of prescription. And for all CKD, whether diabetic or non-diabetic, after 50 years, statin should be a part of prescription to reduce the CV risk. So statin is often missing in the prescription, should be there. Not only for dyslipidemia, but for CV risk reduction. Even if lipids are normal, still that statin has to be there. Bicarbonate is another drug which should be there, should be used judiciously, maintain bicarb around 22. Avoid nephrotoxins, write on the prescription, avoid NSAIDs, avoid aminoglycosides, avoid vancomycin should be mentioned, and avoid indigenous medicines and anemia correction. So these are the 10 basic tenets which should always appear on a prescription of a patient of CKD in stage 1, 2, 3, and beyond. Fine. So here you can see this picture easily summarizes. They are all the stages of CKD. So lifestyle modification applies everywhere. Smoking cessation across the board. RAS inhibition, yes, but we taper it in the last stages of CKD when hyperkalemia becomes an issue. Blood pressure control throughout all the stages. Statins, yes, we don't use statins on dialysis patients because benefit has not been proven. Otherwise, still stage 5 should be used. Optimized glycemic control throughout. SGLT2 inhibitors, they are generally initiated when the GFR is more than 30. But after initiation, if the GFR drops below 30, can you continue? Yes, you can continue. Till what GFR you can continue? You can continue till the patient goes for dialysis. GLP-1 receptor agonists, they are also nephroprotective drugs, and they are used mostly in the earlier stages of CKD. Then metabolic acidosis treatment should start from stage 3B. So we should not overuse the soda bicarb. We should not add a pill burden to the patient, sodium load to the patient who is overloaded or hypertensive in the early stages of CKD. We have to add it when it's required, generally from stage 3B onwards, and treat the underlying cause, avoid nephrotoxins. So these things have to be followed. So you have seen, see, I have told about 10 commandments. They look simple. People may ask why we are reiterating the same commandments. They are important. They should be on the prescription. GFR should be on the prescription. Urine albumin should be on the prescription. And these 10 commandments should be on the prescription. And I have shown the stages when you have to apply them. So that's what you must be asking. What's new? Again, those same 10 commandments. It's important because this is a recent study published from India, from CKD patients in India. And we were also a part of this study, and Dr. Narayan Prasad was the lead author. And you can see horrible figures. In fact, if I may say so, we had studied 4,056 patients. It was a cohort study, and out of that, 3,966 subjects with complete prescription data were analyzed. And look at the findings. RAS blockade only in 48% patients. Statins, only 40% of CKD patients. Metformin, even with GFR more than 30, when it's indicated in diabetic patients, 26%. And iron, mere 31%. And erythropoietin, 3% in anemic patients. So you can see that we know the guidelines. We all know the guidelines, but are we following them strictly? So this article has come this year in Kidney International, and also by International Society and our own society, that we have to focus on these 10 basic measures rather than thinking of new molecules. We should do these things right first. Remember, ladies and gentlemen, testing is 300 rupees, treatment is 3,000 rupees, and dialysis, you can say 30,000 rupees per month, transplant is 5 lakh. So is there a cost benefit in screening and treating? Yes, there is a cost benefit. We are all trying to do the best in our field, but I think the problem is we are all working alone. What we need is collaboration. We need to collaborate. The general physicians, the IMA members, the students, the Ayush workers as well, physicians and nephrologists, if we have to overcome this burden of CKD. Together, I believe we can make a difference. The physicians working with the nephrologists. And the take-home messages on your prescription, if this message goes across, urine albumin and serum creatinine for all high-risk group, and 10-point agenda of treatment on your prescription. This will go a long way to retard chronic kidney disease. So this is the focus this year, bridge the knowledge gap for better kidney care. And thank you, ladies and gentlemen. That's the last slide. And I'll invite the panelists for the discussion. So thank you very much. So now we can move over to the panel discussion. The panel discussion is, the panelists for this session are Dr. Mangesh, and Dr. Anuj Maheshwari and Dr. Sriram. So I'll introduce the panelists. Dr. Anuj, he's a very senior physician, and he is the Vice President of RSSDI. He's the Governor of American College of Physicians India chapter, and he has been a PhD and DNB teacher and guide for last 10 years. He has presented 75 papers in international and national fora. He has 54 publications on diabetes, hypertension, and complications in index journals. And he has been awarded multiple orations in various societies. He is a recipient of 2016 Notable Achievement Award in Hypertension Prevention Control at population level. He is recipient of Health Icon Award. He is recipient of Marvelous Personality of the Year 2017 and Wellbeing Champion 2018 by American College of Physicians. So very honored to have you here, sir. The other panel member is Dr. Mangesh Devaskar. He is an FRCP from Glasgow, Edinburgh, London, FACP, FICP, FGSI. He is a consultant physician and diabetologist at Shilpa Medical Research Center, Mumbai. He's a gold medalist in medicine, MBBS, biochemistry, pathology, microbiology, and pharmacology. He's honorary general secretary of National API, ICP, and PRF. He's editor-in-chief elect of JAPI. He is on editorial board of Medicine Update, International Journal of Diabetes, guest editor of In Sunlight Journal, World Journal of Anemia. He has delivered more than 1,000 lectures at national and international conferences, 64 publications, has multiple chapters, write-ups, and MRCP examiner for Royal College of Physicians. Welcome, sir. Honored to have you here as well. And then we have Dr. Srirang Apkari. He is consultant physician of Udaya Omni Hospital, Hyderabad. He is honorary secretary of API Hyderabad chapter. He is joint secretary Telangana State Research Society of Study for Diabetes in India. He is chairman Academic Council, IMA Telangana State. Honorary editor, Annals, IMA, AMS, and HQRS. Vice president of IMA, Hyderabad City branch. Award for best outgoing postgraduate student, gold medal, multiple gold medals. He is awarded many prestigious editions. And he is the editor of monograph on interpreting and evaluating common lab investigations in clinical practice, multiple publications, and has been quiz master for several quizzes in national and local conferences, and has several fellowships. So welcome all of you. And I would straight proceed with the panel questions. So these are the questions put forth by the general practitioners. Dr. Anuj Maheshwari, this set of questions is for you. What, according to you, are the major barriers to CKD screening in our country?
Thank you, Dr. Manisha, for the kind introduction, and very rightly you have asked this question. I think as fast and as aggressive we are in our tertiary care, the same we are sluggish at the primary care. Our sluggishness at the primary care actually causes this gap between the primary care and tertiary care very long and very many times unsurpassable when patient enters into the kidney diseases. What I am saying this, ignorance among the population and inertia by the primary healthcare physician. People don't know and doctors don't do at appropriate time. And this happens because we don't push them. At this particular time, what we see, a lot of medications are there which should not be given together. As you very rightly said in your presentation also, there are so many comorbidities for which we should make a very specific kind of the prescription. We should take care of the things. Many times people think that blood glucose is just to control blood glucose. It's nothing to do with anything else, but it is our duty. It is make them understand that it is impacting on your kidney also if you are not getting it corrected. Many times our colleagues, those who are working at the primary health care level, they do not know which comorbidities they should think about the kidney problem. Many times we see that people are not doing CKD screening by doing the UACR or microalbuminuria test, what you suggested in patients, those who are having the retinopathy, those who are having the diabetes, those who are having the hypertension. Hypertension is the most neglected thing. Hypertension, people keep blood pressure at the higher level. They think that blood pressure is the higher level is something like a very good thing and something like which is making them very much energetic. So they think that if blood pressure will come down to less than 120 and 80, then probably they may be feeling weakness. Just 1 hour before, I was facing this kind of the patient whose blood pressure has come down for the first time in the life less than 120 and 80, and he was quite worried that, doctor, I am feeling a bit weakness. So these kinds of the mindset has to be resolved. We must work for that, and these are actually the barriers. We should one, ignorance, one, inertia, then there are poor facilities. Many times people are not having enough infrastructure to get done all these kinds of the tests. People are not aware of doing their urine tests, so they many times they just shy of doing the urine test. Once the doctor says you go and get collect your 1-day urine of 24 hours, they don't turn up. What rubbish doctor is saying, I am not requiring all these things. So these are the important barriers what I could understand, and these are the barriers which should be actually targeted. I think you are muted, ma'am.
Yeah, sorry. So how, what role can ACP play in this endeavor, sir? Because now barriers you've highlighted. So what could be, how do we make it possible that anywhere the physician is or the GP is, they should screen, they should do these tests. I mean, how is that going to happen?
Yes, Dr. Manisha, you have very rightly said. We all organization, not only ACP, our API and our other organization, your Nephrology Society, RSSBI, all are working very diligently in this direction, so that people may not face these kinds of the complications. People may not reduce their lifespan, ignoring the small problems in the early part of their life. So many of the times, and you already said that how much it is costing. It is costing so much when we need to give the dialysis and when we need to do the transplantation. And in India, biggest problem is that people have to do it from their own pocket. We are not getting the state-sponsored healthcare facility. So that is more difficult for us to have such a big population undergoing in such kind of the complications related to the kidney. We are not having really that much good of the infrastructure which can help us, but we are having this much of the infrastructure which can facilitate CKD screening in the early part of the disease, CKD screening in the comorbidities. The only thing we need to do, we create more and more awareness. I know, and I'm very much, very well aware that API and kidney organization as well as RSSDI, they all are doing this. What ACP can add it here? We can add some new ideas in creating awareness, in creating advocacy, in creating the more new, we can add up few of the overseas experts to our panel already, our rich panel in India, but we can have the experience from the overseas, not always America. Overseas, sometimes we can share these kind of the experiences with our neighboring countries also, like Sri Lanka, like Bangladesh, like other countries, Nepal, those who can work with us, and we are sharing a lot of similarities with them. And apart from that, we can also add experts overseas, like from US, from the United Kingdom, on the panel of the American College of Physicians. They can easily join and they can add the value what already being done by the API, Indian College of Physicians, RSSTI, and the kidney organization, what you are talking about. So we can just make it more and more stronger, more impactful, as well as more acceptable. And I know it is acceptable now also, but once there will be efforts more, then people will be more accepting, and people will be continuously pushing that these things should be done. When we are doing this for last 25 years about the diabetes, and now people have been quite more vigilant about their blood glucose level. In the same way, we can do this also. I still remember those days when smoking has been banned from the public places, and people were saying that how could it be possible? Because every short distance, the people were found smoking at the road. But now we don't find such kind of people. So everything is possible, and we need only to continue our efforts. We need only to continue make an impact on the target.
Thank you for that viewpoint. Dr. Mangesh, what would you say? What would your role be? I mean, can API make this a priority to spread this message this year? Can you have a roadmap so that the things are implemented? Can you give some roadmap?
Yeah, surely. Good evening, Dr. Manisha, and good evening, everybody. Before I answer Dr. Manisha's question, let me wish all of them, those who have joined today, a very happy International Women's Day. And win this initiative from Dr. Manisha also, probably makes me to think that let them turn out to be the winners, WINNER, where the rest of the mnemonic would be the winners in the national narrative to end the nephropathy. So I believe let them be winners and let them be first. Let this be the first baby step. Now, whether you like it or not, as far as the role of not only Association of Physicians of India, or as Anuj was talking about the role of ACP or IMA or the Nephrology Society of India or International Society, it's the time to act. And the best way to do it is to increase the awareness, as Dr. Anuj has rightly pointed out. And more we talk about it, more and more we insist and pursue on the decipherance of the knowledge, the need for the aggression. And most importantly, if we have got an, I would say, the resources and abilities to convey the message that nephropathy can be prevented, and prevention is the only way forward to stop the menace. Probably that, as one of the active members of Association of Physicians of India, but apart from that, being a physician, being a doctor in the community, I will suggest to most of the people, those who have not only joined, but every organization, no matter it could be a physician organization, an IMA or an ACP or any other organization, we need to take it to the primary care people where it really matters. And you have beautifully shown this in your slides, that if at all we need to talk about prevention, that is the only way to go ahead, because the moment it crosses stage 3B or ahead, you are technically choosing the, chasing the lost boat. So I believe that if at all we need to talk about prevention awareness, as we talk about diabetes, as we talk about hypertension, we also need to talk about the prevention of nephropathy and onslaught of nephropathy, and understand the needs of the hour and make people understand that this is the need for the future.
Thank you. Thank you so much for those brilliant points. Dr. Abkari, at local state level, what is the plan of Telangana API so that no patient is missed, screening of everyone is done? What do you feel would be the action at the ground level, ground zero level?
Yeah, thank you for having me here, and congratulations for a wonderful introductory talk. At the local level, I think we often find camps for screening of diabetes, hypertension, but rarely we do have screening camps of CKD. So I think as an initiative from this day on, we can take this forward, and definitely an online course for training physicians as well as GPs will help. And then when you have a certificate, you go through the module, that awareness increases, and then you pass it on to others. So I think we do conduct camps both from API, RSSD, etc. It predominantly restricts itself sometimes to diabetes detection camp or other activities. But once we focus on CKD, then probably that impetus will be gone. And according to me, the percentage of GPs and physicians also practicing the protocols is very less. The first thing is the calculation of EGFR is not done, and that leads to creatinine of 1.4, 1.5 also being neglected, and that seriousness sometimes does not come. Suggestion would be that we can probably also take help of our laboratory parameter partners, and then tell them that whenever you report a creatinine, maybe which is abnormal or above 1.2, yourself give a EGFR indicating it is low, so that that awareness will be created, and then people will restrict the use of nephrotoxic agents and other things. So that can actually be followed, so that that awareness that creatinine is looking normal is not there, but if you calculate the GFR, it is actually low. So that probably will go in a long way in helping us to screen CKD patients and also prevent its progression, so that burden on nephrologists in turn will come down.
Yeah, thank you. Thank you for those valuable suggestions, Dr. Sriram. So you have given some practical points, which we can, I think, as a state level, we can focus on those. So thank you. It was a fruitful panel discussion, and probably we have some action points which we might follow up on. So I think now we'll move over to the next topic, which is another important topic again, and very confusing topic for many, because lots of questions arise here, diet and CKD. And to deliver this talk, we have Dr. Umesh Khanna. He is Director, Kidney Associates. He is Consultant Nephrologist, Asian Heart Institute, Karuna Hospital, Suchak Hospital. He holds positions as Chairman, Mumbai Kidney Foundation, Trustee of Sapiens Health Foundation, Secretary, Mumbai Nephrology Group, Secretary, Amar Gandhi Foundation, Project Coordinator for the G1 Spurt Program, IMA National Chairman, CKD Prevention Cell. So absolutely right person in the right place at the right time. His areas of interest are community dialysis, preventive nephrology, and nephrourology. And one thing what is not mentioned is very witty person. So over to you, Dr. Umesh, for your presentation.
Made my life difficult about being witty. I will have to hunt for some jokes. Thanks, Manisha, for that brilliant introductory talk, and really it was impressive. It makes my life a little difficult to follow on somebody who is such a good speaker. Let me share my slides. Yep. Right. Diet in CKD, pearls for practice. This I will start at 7:40 and you have given me 15 minutes. Let me stick to time. So, doctor, what should I eat? And that's the most important question for the patient and caregiver, but the least important for the consultant. And not enough importance is given in our curriculum also. In fact, not enough time is available to people like the stalwarts who are on this program today. And that's a very irritating question which the people keep on asking. So obviously some of the answers are not very great. To prevent, what's the role of diet in CKD? Why should we have this topic which Manisha thoughtfully decided? That's because to prevent CKD, you need a dietary control. And as Manisha knows, and all of you all probably are aware that we at the Mumbai Kidney Foundation always talk of Ek Chammach Kam campaign, which basically means reducing salt, oil, and sugar by 30%. Basically, we're talking of controlling non-communicable disease. I think there is a lot of disturbance, the background. Okay. So a diet will arrest or slow the progression of CKD. It will reduce uremic symptoms, prevent malnutrition, correct metabolic acidosis, suppress uremic bone disease, control hypertension, fluid overload, hyperkalemia, prevent hospitalization, prevent sudden death, and so on. So you could kill many birds with one stone. In fact, today, most guidelines put medical nutrition therapy as one of the top-notch, items in the management of many diseases. So, really, in some parts of the country and many doctors, when a diabetic CKD goes and they're not aware of how to manage a CKD, a diabetic CKD went to a doctor who promptly advised the patient, stop proteins for azotemia control, stop carbohydrate to control diabetes, stop fats to avoid atherosclerosis and CVD, no salt so that we can control your blood pressure and swelling, no spices because you have a lot of gastropathy related symptoms, no fruits so that you don't develop, hyperkalemia, rest everything you can eat. So if you don't listen to talks like what Manisha has asked us to talk about, the answer is we should go to a qualified dietitian. So one of the first pearls is that to manage CKD, either you learn or refer to a dietitian. Now, what are the challenges of diet in CKD? We all know that once the nitrogenous waste products increase, it may distort the taste, smell, and it may blunt the appetite. Uremia causes gastroenteropathy, which reduces appetite. It causes a lot of fullness, bloating, constipation, or diarrhea, or both. And of course, in advanced stages, and if the diet has not been handled well, you will have muscle wasting, fat wasting, leading to malnutrition, sarcopenia, frailty, especially in elderly. And we all know how difficult it is to manage these malnutrition symptoms. Not only that, CKD has its own problems of fluid electrolyte imbalance leading to altered sodium and potassium. There's a lot of metabolic acidosis and its problems, salt retention, fluid overload. So you need to handle at all these levels the diet. The other issue is that the Indian patient cons are easy to handle. Indian patients also are difficult. Renal diets are very restricted. And the spicy Indian palate believes in delicacy, fasting, feasting, etc. From childhood, we've been, trained to have a classical thali with ingredients of achar, chutney, papad, etc. So we are also very poorly informed because most conferences don't talk or give too much importance to diet. And hence, we should have many of these meetings. So malnutrition, this is another area where Indian patients are different. Malnutrition is very highly prevalent in Indian CKD patients. It is underdiagnosed and hence undertreated. And it could, we all know, lead to infections and atherosclerosis or inflammation, etc. The other area which is important is the Indian diet is predominantly vegetarians. And cereals and pulses form a major part of the diet. Even the non-vegetarians eat non-veg only once a week. Its Indian diet is inadequate in calories and high biological value proteins. And therefore, it's important to have dietary recall before prescribing diet. In fact, the entire country could be on a CKD diet if you don't really, if you discount some of the very high non-vegetarian people. So blind protein restriction could be harmful. Now, when you have to practically give diet, how do you proceed? So prescribing diet means first you must have a nutritional assessment, which would mean history and clinical examination. You should also assess some of the lab parameters like albumin, cholesterol, urea. Then there are certain specific tools available for nutrition assessment. And most important, very simple, is the dietary history and dietary recall. So, in the medical history, we always look into what are the, how much is the amount of residual renal function? Is he having enough urine output? In examination, you look for whether there is edema, whether you really require to restrict proteins, are there nutritional changes in the skin, eyes, hairs, etc. And in fact, most good dietitians will take a proper dietary intake. There are different tools assessment available, especially the simple blood tests and then specialized nutritional tools. Now, if you want to know the demystified renal diet, then one thing is sure, there is nothing like a CKD diet. Each case is different, requires a diet specific for his or her condition. So it's not a one size fits all. There can be a CKD case with normal blood pressure, no edema. They don't require sodium restriction. Some cases are very good urine output. They don't need any fluid restriction. There can be CKD cases with normal or low potassium. They don't need potassium restriction. And there are many cases where there is no protein restriction required and they could be on almost normal diet. So therefore, it's important that the history and dietary recall is taken in all CKD patients. What are the principles of dietary modification CKD? You have to look into calorie intake, protein intake, sodium, potassium, phosphorus, and fluid, to say the least. So if you look into these things and consider the practical areas, then at least you have a working dietary advice given to a CKD patients. Of course, the CKD in dialysis patient is different from, the diet in dialysis patient different from non-dialysis. So that's one of the most important areas. And unfortunately, a lot of people who were given diet in the non-dialysis times continue to take that diet and therefore become malnourished when they go on dialysis, knowing fully well that, at least they don't know, but we as clinicians know that those who are on dialysis require a different type of diet, right? So calories are important because it prevents malnutrition. If adequate calories are not provided, patients will recover calories from proteins and patient will lose his muscle mass, causing protein energy wasting. Now, which are the high calorie dense foods, especially in CKD5 dialysis? CKD5 on dialysis requires high calorie dense foods because he is most likely to become malnourished. And although I will list some of these items, they are not meant for everybody. The dietitian only will decide who should get what. But gravy, cream, salad dressings, jelly, jam, sugar, jaggery, these could add calories provided the patient's clinical condition and the electrolytes, potassium, etc., or sugars allow. So decide as per patient's clinical picture, and the dietitian generally looks into it. Sabudana or sago, arrowroot, these are pure, carbohydrates, or these are pure without protein. So they will be good in non-dialysis patients. There are some patients who will require both calorie and protein dense, especially those who are on dialysis. So these people require stuff which will give them calories as well as look into the protein part. So cheese, ice creams, custards, puddings, milkshakes, yogurt, nuts, cream wala soups, eggs, high protein milk. Some of these could be useful in patients who are on dialysis. From calories, we move on to proteins in CKD, and we all know that patients with CKD accumulate a lot of waste products, and therefore reducing proteins in diet theoretically will slow down the progress of CKD, especially proteins which are animal proteins. If you reduce them, it may definitely help. But while doing so, one must ensure that first-class proteins are given with any restricted diet. What's the rationale for dietary protein restriction? Because protein restriction will ameliorate uremic symptoms. It will decrease the load on the remaining nephrons and slow down the progression of kidney disease. It will improve proteinuria and albuminuria. And therefore, a lot of people have this misconception that if there is a lot of proteinuria, you give high protein diet so that you are replacing it. That's not the way to treat. And of course, it will improve metabolic profile. So what's the standard dietary prescription for a low protein diet? The calories should be around 30 to 35 kilocalories per kg per day. Proteins between 0.6 to 0.0 gram per kg per day. You should look into what is eating. A lot of our patients are eating almost 0.6 to 0.8 only. So you don't need to restrict any protein in these people. In fact, if you blindly restrict protein, then you'll make them malnourished. Potassium restriction will depend on the potassium level. Sodium restriction will depend on whether patient has swelling, high BP, etc. Fluid restriction again will depend whether he's fluid overloaded or not. Phosphorus restriction is between 800 to 1000 milligrams. Now, protein restricted diet could be a double-edged sword if not supervised, as I've been mentioning again and again, because malnutrition is rampant in our country. So in a very low protein diet, we sometimes tend to add amino acid, keto acids, etc. Protein restriction is only for those who are taking more than adequate proteins. They are for those who have a very slowly progressive disease and who are nutritionally educated and under surveillance, so that you can actually decide their right. So roughly the dietary protein restriction, if you want to go beyond or below 0.8, then generally we supplement it with keto analogs so that it helps in preventing malnutrition. What about who should be advised? As I said, those who have a slowly progressive CKD, and that too at an early stage of the disease, with good appetite, good nutritional status, those people you can go ahead with good protein restriction. Proteins, okay, foods which are poor in or those who have very poor proteins. Fresh fruits, vegetables, sugar, honey, jaggery, cooking oil, ghee. These are items which have very little proteins and more of calories. I'm not going to give the actual prescription of the low protein diet. Let's go to potassium from protein because it's very important constituent. High potassium CKD patients can kill the patient. This is a very drastic statement, but so true. And in view of ACE-ARBs, which Manisha says we should use it very early, the importance of dietary potassium, which should be reduced even from an early stage so that you can easily give ACE-ARBs to the required level. And that's an important message from me. If potassium is less than 5, there is no need for aggressive restriction, because excessive dietary restriction can expose patients to less heart healthy and more atherogenic diet. So that's why, again, it's a double-edged weapon. You need some potassium restriction in some patients, but not in all patients, because if you keep on restricting potassium, it may be harmful. So excessive potassium restriction can also cause constipation, which may actually result in higher gut potassium absorption. We all know that fruits, dry fruits, chocolates, raw vegetables, salads, etc., very high source of potassium. So in given cases, you may restrict that. There are 5 fruits which are easily allowed because they're low in potassium: guava, papaya, apple, pear, pineapple. Leaching of vegetables, dals, pulses, potatoes, it helps in reducing potassium. And when you make chapatis, double sieving the wheat flour can help in making rotis. Now, all this is only for those who have very high potassium. In most of the average cases, not many of these will be required. What about fluids? So fluid restriction, fluid restriction is required. And how do you know patients fluid restricted or not? Go by the daily weight, which will guide fluid therapy, especially those with poor urine output. Tea, coffee, milk, chas, lassi, curd, etc., all of it will come into fluids. Now, to restrict fluid, what are the practical suggestions? Drink very cold water. Use a candy or a peppermint or ice cube to quench your thirst. Use flavored ice cubes kept in the fridge so that helps in quenching your thirst. Instead of milk, you can use paneer for high protein. Instead of, you can use hung curd instead of the standard curd. Use thick dals. Whenever you need to drink water, use a very small cup or a glass to have liquids, and avoid salty and fried foods because they will help to decrease thirst. Fluid restriction is, we move on to the salt restriction, which is a topic very close to my heart. And we talk about salt restriction, CKD for protection from hypertension, even proteinuria. If you have a lot of proteinuria, salt restriction will help. Or fluid overload, that needs to restrict salt. Practically, how do you restrict salt? So roughly a flat teaspoon will be around 4 grams, and that's what is recommended overall. But if you have a lot of fluid overloaded patient or pulmonary edema patients or heavy proteinuria patient, you may restrict to 2 to 3 grams. What is 2 to 3 grams? 1 pinch of salt is 1 gram. So accordingly, you can decide on how much protein you are going. Which are the foods high in sodium? We all know, but just to remind you that cheese, pasta, noodles, the younger generation takes, and a lot of people don't understand that the noodles actually are one of the richest sources of salt. Soups and snacks and dips, sauces, salads, these are very high in salt. All high sodium food need not be salty, and a lot of sweets like cookies, cakes, pastries are also high in sodium. How do you restrict sodium? Use other flavors: lime juice, vinegar, kokum, tamarind pulp, amchur powder, spring onions, green chili, and cinnamon powder, and so on. So there are certain adjuncts you can use. Of course, when I talk of chutney, you're not making it with salt, but with other ingredients, guava, apple, kokum, etc. So these things help in adding to the taste of a patient who is already, Manisha is not allowing me to give the recipes of all these chutneys, but maybe some other time. Phosphorus again is an important complication, hyperphosphatemia for CKD. But there are two types of phosphorus, organic and inorganic phosphorus. Phosphorus restriction should primarily include processed food should be restricted, cola should be restricted, and not so much of plant proteins. They need not be restricted. And these are the high phosphorus foods: non-veg foods, cheese, koa, egg, pulses, nuts, chocolates, and so on. So to summarize, we have nutritional recommendations, which today's time, 15 minutes does not allow me. But what is different from previous guidelines? The most important difference is the importance of plant-based diet in preference to meat-based diet. So I'm not talking from any political party, but the plant-based diet should be preferred in all CKD patients. It not only helps in CKD, but also helps in diabetes, hypertension, obesity. Meat-based diet is acidic. Plant-based diet is also with less uremic toxin production. It reduces constipation. It helps in colonic excretion of potassium also. They also contain less salt, and therefore you can control metabolic acidosis very easily, reduce the CKD MBD, and slow down the progression of CKD. So plant-based is a winner. In summary, fluid restriction is difficult but important. Important as it helps in reducing hospitalization in LVM and left ventricular failure. Potassium is a double-edged weapon, should be managed cautiously. Dietary advice should be culturally sensitive. वो सब North Indian को पूरा दिन rice खिलाते हैं, they're unable to eat any kind of food. So it should not be too restrictive, and in keeping with social and economic reality of the patient, that only will ensure adherence. Dietary modification can prevent CKD, slow down CKD, minimize complications, reduce hospitalization. There is no one size fits all. All patients don't need protein restriction. Calories should be adequate to prevent malnutrition. Salt restriction is important, difficult, and generally goes along with fluid restriction. Salt substitutes are dangerous, and a lot of people consume potassium salt, and therefore one needs to be very careful. And remember, all sodium is not salty. Thank you. And Manisha, I had to rush it for 15 minutes of diet, which I haven't yet learned in so many years. Thank you.
So thank you, Dr. Umesh. I mean, you have done a fantastic job and covered all the important points, and you have made some statements which are going to stick in everybody's head, I guess. The noodles are oodles of salt. It's really
Yes.
nice, touchy, and you have given practical tips how to reduce the water content of so many foodstuffs. So really great how to quench thirst. So I think it was a good learning experience. Can you unshare your screen?
Oh, sorry.
So thank you. Excellent. I mean, in 15 minutes, you have done a great job, covered most of the topics.
Why can't I?
Yeah, I think.
Sir,
yes.
I had done. Sir, I had
Okay,
done.
fine. Thanks, Manisha. Women in nephrology can manage all this in 15 minutes. Men in nephrology find it very difficult whenever you talk of that.
So I think it was a wonderful talk, and we have learned a lot of points from this. So let us have some discussion about this topic and the topic related to diet. And for Dr. Umesh's topic, we have again very well-known panel members. We have Dr. Bhalla. Dr. Bhalla is Chairman and Head of Department of Nephrology, Sri Gangaram Hospital, President of Indian Society of Nephrology, President Society of Renal Nutrition and Metabolism. He is a Padma Shri awardee and a BC Roy awardee. Welcome, sir. It's nice of you to find time in your busy schedule to join us. We have Dr. Vasant Kumar, sir. He is also a very senior physician. He is president of RSSBI, senior consultant in internal medicine and geriatric medicine in Apollo Hospitals. He is founder of Diabetes and You Society. He has several guest lectures and publications to his credit. And we also have Dr. Rakesh. Dr. Rakesh is president of Endocrine Society of India. He is vice president of South Asian Federation of Endocrine Society. He is second editor of Tropical Endocrinology, Endotex Online, editorial board member of IJEM. He has several awards to his credit, and he received the Best Teacher Award in Medicine from Government of Telangana. And he has around 150 publications in various national and international journals. And he has authored several chapters in textbooks and has written monograms on diabetes. So welcome to all the three panel members. So Dr. Balla, I wish to ask you, what should ISN do to promote awareness about healthy diet? We all know what a healthy diet looks like. But still, I mean, even if you look around you, most of us are on an unhealthy diet. The CKD patients are on an unhealthy diet. And as Dr. Umesh said, many of the patients of CKD patients also are on a restricted diet. So what message would you give to GPs regarding diet for their CKD patients? So two questions. I mean, how do you implement healthy practices through the ISN? And how do you teach the GPs how to prescribe diet rightly for CKD patients?
Yes. Thank you, madam. Thank you for giving me the opportunity to participate in this very important webinar. Now, as we all know, starting from the days of Ayurveda, that all diseases start from gut. So it is not only about kidney, it is about all the diseases like diabetes, hypertension, CKD, malignancy, metabolic syndrome, cardiovascular diseases. So it is actually prevention for most of the diseases, and we are what we eat. So I think we have to be very careful what we eat. So we have to have a very healthy lifestyle in addition to healthy diet. So already you have shown in your slides, Dr. Khanna has also shown that healthy lifestyle and healthy diet both are important for prevention of disease. Actually, we have to stress on preventive nephrology and preventive medicine, because as you have already shown that 2 lakh new patients of ESRD are added every year. And common causes are diabetes, commonest. Then we have CKD of unknown origin and hypertension. So even unknown origin is because of certain pollutions, pesticides, and various other toxins. So all these can be actually, so we have to go for preventive medicine. And for this preventive medicine, one of the prevention is healthy diet. So what is healthy diet? So we have to see that healthy diet is actually one diet which has a lot of colorful vegetables. That is very important. Like we have Shimla mirch, capsicum. So we have red, yellow, green. So this kind of color, lot of color vegetables, color fruits we have to consume. We have to make part of our diet, because these supply a lot of phytonutrients or phytochemicals. These are natural bioactive compounds, and they help in our gut health promotion. And this is a rich source of vitamins, minerals, and antioxidants, and make a very robust immune system if we consume various different kind of colors in our diet. So I will stress today, although very rare to talk on this, that colorful vegetables, colorful fruits, one has to include different colors. That's why we have now brinjals of white, green, as well as purple colors. So colors are important. Then, as our Narendra Modi Prime Minister always stresses, mota anaj, that means millets. So what our ancestors were eating, what absolutely healthy pattern. We have left all those millet grains like jawar, bajra, ragi, and we have shifted now to maida, refined foods. Similarly, we were consuming good, that was unrefined sugar. Now we are using refined sugars. So we are using sulfur containing sugars. Again, we are using trans fats. A lot of consumption of trans fats in our diet. lot of sodium, as shown by Dr. Umesh Khanna. Your white bread contains a lot of sodium. Maida is in white bread. It is in on the normal grain and the flour which we eat daily. And majority of the population is in rice-based diet. Then we have a lot of consumption of saturated fats and trans fats. So I think we have to avoid these and shift to healthy pattern diet. That will be my message, that we have to go for prevention, because we are not able to manage this much of load of a CKD population going to end stage renal disease and requiring dialysis and transplantation. Then second is about protein, that although normal protein intake we should have is 1 to 1.2 gram per kg body weight. And if we see calories, 35 kilocalories less than 65 and less than 35 if it is more than 60 years age. But this calorie, 60% has to be from carbohydrates, 50 to 60%, 30% should be from proteins, and 20% should be from fat. But if you see in Indian diet, our diet is actually predominantly rich in carbohydrates. So plus, in addition to low activity or inactivity, less physical exercise, this definitely is a disaster for creating all kinds of diseases. So that will be the message to all physicians, primary care physicians from my side, that we have to promote healthy lifestyle. And for this, we have to involve the dietitians, renal nutrition, not renal nutrition, but general nutritionists. That help we have to, in fact, we have to look for that help, because awareness of healthy diet, this advice has to be given to all the general physicians and healthcare professionals. That will be my message from Indian Society of Nephrology, to decrease the incidence and prevalence of chronic kidney disease in our country.
Thank you very much for those messages, especially the message about colors in diet is pertinent, and we should also practice what we preach. All of us should adopt a healthy lifestyle as well. So Dr. Vasan, what practical diet plan do you suggest for diabetic and hypertensive patients who are at high risk? Because now metabolic syndrome, obesity are assuming high proportions, epidemic proportions. So how does RSSDI plan to educate people about healthy foods? What I mean to ask is, do smartphone apps help? Many people are now on smartphones, so they have apps. What do you feel? I mean, how can we inculcate these healthy eating habits in the population? Dr. Vasan?
I think Dr. Vasant Kumar is not there. He has left. He is. I can see a message in the group that he has had some urgent work and is leaving.
Okay, no problem. So you can take the questions.
Yeah. So I think we had a very good discussion, starting with your introductory talk, and also Dr. Umesh Khanna has given a very good overview about diet, and as Dr. Bhalla also said, that we are what we eat. And I think the important message that he has given is that we need to add color to our diet. As we add color to our diet, then the diversity increases. Wherever we go, the diversity is actually important, and that increases improves the health and improves the nutritive value of the food, and also reduces the problems that happen with the food. So I think if you look back at the growing epidemic of if you look back at the last few decades, last 4 or 5 decades, where we are seeing that there's a tremendous increase in the prevalence of obesity, cardiovascular disease, diabetes, hypertension, renal disease. As we see in all these years, the major change that has happened is a change in the lifestyle, and even of the lifestyle changes that we are saying, the major change is the dietary change. The promotion of fast food, which has probably made the maximum impact on the prevalence of these problems. Although all the physical inactivity is also contributing, but I think the extent of contribution of physical inactivity is probably to a lesser extent as compared to the dietary change, as was highlighted very well by both Dr. Umesh Khanna and Dr. Bhalla. They have spoken about that. So I think they have very rightly pointed out that we need to increase the awareness about a healthy diet, and the questions that you were asking, Dr. Vasant Kumar, was also about how we need to encourage diabetic patients to adopt a healthy lifestyle and a healthy diet so that they can prevent the development of nephropathy. That's the most important important message that we want to convey today. Whether apps help, yeah, we have several different apps available now. I mean, different apps have been developed. Some of them are really backed by scientific evidence. We have several apps which are now backed by scientific evidence, which have been used by RSSDI members and by our society also. We have seen that what we have seen is that there is I mean, scientifically we have shown that with the lifestyle changes which are advocated by these in these apps, and also a small amount of nudging that is done to the patients, little reminders about what they should eat, what they should not be eating. Those things have been able to bring down the HbA1c on the average by 1 to 1.5% by just the use of the app. So that has been shown in some of the apps, at least some of the apps which have done these studies. They have shown that this amount of difference can be brought about. And so I think that's a good tool that has to be used. We have data. We have two published data. I mean, good published data from Dr. Ramchandran, who has used this SMS messaging. He didn't even use an app. He used just SMS messaging to people with pre-diabetes, trying to see whether we can prevent their progression to diabetes. And this is published in Diabetes Care. He has shown that by the use of these small SMS messages, you can prevent their progression. You could significantly prevent the progression from pre-diabetes to diabetes. So we have quite good data to show that use of these apps and use of all these tools that we have at our hands today, we can actually effectively use it to prevent progression of either from pre-diabetes to diabetes or development of diabetic nephropathy. I'm sure this is a good area to research on and bring out some good information about how these can be used to prevent the progression of nephropathy also, and development of nephropathy also in patients with diabetes. So that's one aspect. Now coming to what the ESI has been doing. Well, we have been doing a lot of talking. I mean, as most of the societies have been doing. We have had recently concluded with last 1 week only. We had a whole week long program on obesity, because we just had the obesity day on 4th of March, just before the World Kidney Day, and today is Women's Day, and we have the World Kidney Day coming up, and 2 days before we had the World Obesity Day. And again, the theme there was that everyone needs to act. And so we had a series of webinars covering different aspects of obesity, not only discussing about the impact of obesity, but also discussing about the dietary aspects, how these can be brought about, and also about the psychological aspects, how these things can be implemented, whatever advice we are giving, how we can implement that, how we can see that people are able to follow this advice. So we have been doing a lot of these programs. They were focused on the primary care providers, the general practitioners, the physicians, and all doctors at large. And now, and also we have been doing a lot of programs on the Facebook Live. Even the RSSDI has been doing a lot of programs. I've been part of that also, and also through the Endocrine Society, we have been doing programs for the general public. We are trying to inculcate a healthy lifestyle by educating people in general. People about a healthy lifestyle and all that. So we have been doing all these things, but although this may be making some impact, but I think what is needed is that we need to all get together and work together to make a significant impact, actually, because what we see is that individually whatever we do may not be providing that much of impact, because this is a huge burden. The burden of non-communicable diseases, the burden of diabetes, burden of CKD, which you spoke about, is a huge burden which cannot be individually tackled by society or one,
I'm having
one
trouble
group of
hearing
people.
you.
but we need a concerted effort, and towards that end we from the RSSDI and the Endocrine Society, we are trying to get together the API, the Cardiology Society, the Nephrology Society, and the I mean all the concerned societies together, so that we can work together and bring about a meaningful impact on these problems. And then we also have an advocacy committee in our society, where we have been trying to pass on information, I mean give information to the policy makers about what should be what they should be doing about in terms of promoting healthy foods, and stop the promotion of these non-healthy foods, as you know, because a lot of advertisement going on which is promoting these unhealthy foods. And although we know that I mean we just heard about the noodles and all that, but the noodles are promoted like very good food for children, and that's, I think that's where the problem starts, and we should try to see how we can bring about a change in that. So I think there's a need for a concerted effort, as you have rightly highlighted, that all of us need to come together, to work together to make a change, so that we can prevent this epidemic or a pandemic of non-communicable diseases.
Thank you so much. So I think we'll now move over to the next topic. This is hypertension management in CKD, and this would be delivered by Dr. Narayan Prasad. He is well known to most of us. He is head Department of Nephrology, SGPGI. He is Honorary Secretary, Indian Society of Nephrology, Deputy Chair of South Asia Regional Board of International Society of Nephrology. He is a council member of International Society of Nephrology, Asia Pacific Society of Nephrology, Executive Member, Renal Sister Program, Chairman, Quarantine Committee, SGPG Lucknow, former Secretary of Indian Society of Organ Transplant, former Secretary, Federal Cardiac Society of India, former Treasurer, Indian Society of Nephrology. He is a member of Pradhan Mantri National Dialysis Program, and he has 242 publications and 22 book chapters. So he has held whatever positions are there to be held in nephrology. So nice having you here, Dr. Narayan. And I request you to lead with your talk on hypertension management in CKD.
Thank you, Dr. Manisha Sai, and all the members of Women in Nephrology for this opportunity to speak on the today's very auspicious day, where we are celebrating a week of World Kidney Day, but today is fortunately International Women's Day. So thank you everyone for giving me this opportunity. So I have been told to speak on hypertension in CKD and pulse of management. And pulse are loved by most of the women, and it is International Women's Day. Let us see how many pulse comes out of this presentation. So we all understand that hypertension is both a cause and effect of the CKD and contributes to its progression. And approximately almost all or 90% of the CKD patients had hypertension during the course of the disease. So how does the CKD cause hypertension? Three important mechanisms. One is the sodium dysregulation, decreased sodium excretions leading to sodium retention and hypertension, increased sympathetic activity, and alteration in renal angiotensin aldosterone system that we all understand that leads to hypertension. And at the baseline is that reduced glomerular mass, reduced nephron mass, and that leads to all these activity. In contrast, how essential hypertension is different from hypertension due to CKD? Essential hypertension usually is a slowly progressive killer and leading to chronic kidney disease. Only 10% patients in 15 to 20 years develop CKD because of systemic hypertension. If it remains uncontrolled, it causes kidney injury by causing arterial sclerosis, glomerular sclerosis, tubular atrophy, and interstitial fibrosis gradually, and ultimately leads to end-stage bleeding. So CKD, increased BP in the CKD happens because of the sodium and volume, endothelial dysfunction, renal angiotensin aldosterone sympathetic activity, and large arterial stiffness. Many times that is also happening because of the vascular calcification, which happens very specifically to the CKD MBD disorder, mineral bone disease. And one of the very important topic always, we have talked a lot about the salt, about the hypertension, salt sensitive hypertension, chronic kidney disease. What happens there, beyond aldosterone, proteinuria, metabolic acidosis, that activates epithelial sodium channel, and there is distal tubular sodium absorption, and that leads to salt sensitive hypertension. So we have talked a lot about the salts, so we are not going to cover in the detail. So CKD stages, cardiovascular risk and ESRD risk for those particularly at stage 3 and stage 4 of the CKD, the risk of the death due to cardiovascular disease is higher than the risk of progression to ESRD. If you are not controlling hypertension, you are more likely to die because of the cardiovascular disease before progressing to your end-stage renal disease. So it is very important to control the blood pressure, at least at the stage 3 and 4. And all stages it is important, but in stage 3 and 4, it is very pertinent to control the blood pressure. So measurement of the BP in CKD, what the KDIGO recommends. So oscillometric BP device may be preferable now. Adequate preparation of the BP measurement is important. Note the type of the equipment that came from the KDIGO recommendation of 2021. An automated office BP, either attended or unattended, may be preferred method of standardized office BP measurement. Out of office BP measurement with ambulatory blood pressure monitoring or home BP monitoring be used to complement your standardized office BP reading for the management of high blood pressure. So what are the types of BP measurement? Ambulatory blood pressure management is thought to be the best. Home monitoring has ease over the office BP, and office BP should be in a standardized manner. So clinic BP of 140 by 90 millimeter of mercury equates to a home BP value of 135 by 85 millimeter of mercury, or daytime value of 135 by 85 millimeter of mercury, and nocturnal ambulatory BP monitoring of 120 by 70. So office monitoring you can equate if you do not have the phenotypes of hypertension with a varying degree of cardiovascular disease. To understand about the different phenotypes, one is the sustained normotension. That is absolutely normotension, normal office BP, and normal home BP. So normotensive. If you have only high office BP, white coat hypertension. If you have both high home and office BP, then sustained hypertension. When you have the normal office BP, but only high BP at home, that is called the masked hypertension. And you will look at here, masked hypertension, who has normal clinic BP, but high 24-hour ambulatory blood pressure monitoring has highest risk of the all-cause mortality. So that is very important part. We have heard many of the patients are dying suddenly. It might be because you might be missing many of the masked hypertension. So coming to the management part, non-pharmacological management, salt restrictions, Dr. Umesh Khanna has already covered it. Just giving a exact objectivity to this here, reducing dietary salt intake to a 50 millimole per day or 3 grams of the salt, decrease systolic BP by approximately 10 millimeter of the mercury. So KDIGO recommends that sodium intake of less than 2 grams per day or sodium chloride of less than 5 grams per day in patient with a high BP and CKD. But what is important, the DASH type of dietary approach to stop hypertension recommends some of the diet which contains potassium. Particularly, you have to understand salt substitute, Lona salt, but that is rich in potassium. If the patient is CKD, we must keep in the mind whether what the potassium level of your patients. In hyporeninemic hypoaldosteronism, where again the hyperkalemia is when there is any causes of the impaired potassium excretion because of the potential of hyperkalemia. So we must understand when you are substituting salt with the other salt. So what we are doing, what is the stage of the chronic kidney disease? And again, we have to take cautions when you have the salt losing nephropathy. So that needs a little bit more salt rather than restricting the soul. So weight loss is another important parameter. Weight loss is effective in reducing BP and proteinuria and based on the CKD progression. And overweight patients with the CKD and proteinuria of more than 1 gram 25, mean weight loss of 4% can reduce proteinuria by 30%. So just 4% and proteinuria reduction of 30%, you can see the advantage. But it is very difficult to adhere to the lifestyle modification. And a master plan study which has been conducted in Netherlands has shown if you involve the nurses in adherence program, then adherence becomes very much improved. So we should try to involve our paramedics for such a cause. Physical activity by KDO recommendation, what they recommend. Patient with a high BP and CKD be advised to undertake moderate intensity of the physical activity or a cumulative duration of at least 150 minutes per week. So 20 to 25 minutes of this moderate exercise is sufficient to a level compatible with the cardiovascular and physical tolerance. So many patients have comorbidity of the cardiovascular disease. Many patients are frail. So you have to judge how much intensity of the exercise you can recommend. Renal protection and cardio protection trials, I'm just talking about. There are 3 important trials which happens on renal protections, which are here highlighted in little green. There are 2 important in cardiovascular, which is highlighted in pink. So what we can see here, MDRD, REAN and ASK, all particularly the MDRD where the proteinuria of more than 1 gram and MAP, mean arterial blood pressure of 92 mg, intervention group has shown slow eGFR decline in intensive group. Again, ASK trials has also shown the slow eGFR decline in the intensive groups. In aspirin trial and accord trials, when they have take the systolic blood pressure of less than 140 versus less than 120 milligram, again here saying decreased cardiovascular disease and death in intensive group. That is the aspirin trial. That is the one of the latest trial published in 2015. So what for the CKD in aspirin trial, there was a lot of cardiovascular benefit, but in those with the CKD, which was approximately 2,600 patients with the mean GFR of 48 ml per minute, intensive BP control reduced all-cause mortality with the effect size similar to that seen in the overall cohort. But there was no effect on renal outcomes, including the rate of the eGFR decline. But the catch point was here, the patient with the proteinuria of more than 1 gram have been excluded from this. This might be the reason of why there was no significant effect on renal outcome in aspirin trial in CKD patients. What should be the blood pressure target? Different guidelines, different target. KDO 2021 recommends patients with a CKD and high BP target systolic blood pressure of less than 120 millimeter of the mercury. When tolerated, it is very important using standardized office BP measurement. American College of Cardiology and American Heart Association recommends less than 130/80. Again, the European Societies recommends 130 to 139 millimeter of the mercury, and Hypertension Canada recommends systolic blood pressure of the less than 120, similar to KDIGO guidelines. Why there is different guidelines different? Because this all depends on the study which has been included in the recommendation and how much importance has been given to which study. So at present, latest guideline of 2021 of the KDIGO, systolic blood pressure of less than 120 if the patient tolerates well. But it is potentially hazardous to apply the recommended systolic blood pressure of less than 120 millimeter of mercury, particularly if they have the limited life expectancy or there is symptomatic postural hypotension. So you should judge and individualize the target blood pressure, particularly our patients of the advanced chronic kidney disease, patients on the dialysis, many renal transplant recipients with a renal failure have really they becomes frail and they cannot tolerate this much of the type blood pressure control. They may be frail, not be able to exercise. There is presence of anemia, comorbidities, and one of the very peculiar comorbidity, vascular calcifications because of the CKD-MVT disorders can be there. So coming to the pharmacology recommendation, renin-angiotensin and aldosterone system blockade, AC inhibitor, angiotensin receptor blockers, there is no doubt, has been accepted as first-line management of hypertension in patients with a proteinuric CKD. Offers both cardioprotective and renoprotective properties. Reduce systolic blood pressure by 20 mmHg in patients with hypertension and CKD. BP reduction is similar to the BP reduction offered by calcium channel blockers and diuretics. And these agents offer a BP independent reduction in proteinuria in both diabetic and non-diabetic CKD. So it is well accepted, nothing new. So what controversy came when the paper came in the Lancet in 2005? What they have told, the AC inhibitor or angiotensin receptor blocker, when they have been compared with the placebo, they have shown very good effect on relative risk of 0.71 for doubling of the serum creatine and relative risk of 0.87, a small benefit on ESRD. When they are compared with this placebo, then there was very good effect. When they are being compared with any comparative antihypertensive, the benefit, particularly in the patient of the diabetic nephropathy, there was no benefit was seen in comparative trials. And placebo-controlled trials of AC inhibitors and ARB showed greater benefits than comparative trials on all renal outcomes. So they recommend that calcium channel blockers and thiazide or thiazide-like diuretics should be considered as alternative first-line choice in this population. So this controversy came from this paper, but still there are strong evidences AC inhibitor and angiotensin receptor blockers should be used in all proteinuric patients. What about the AC inhibitors and angiotensin receptor blocker combination? Look at the cardiovascular protection and renal protection. Two studies, on target study and V and nephron D study, both shown no significant reduction in the primary outcome of death from cardiovascular MI, stroke, and heart failure, but there was increased risk of AKI in on-target study. And again, here also in renal protection, there are also no significant reduction in the primary outcome of progression of the CKD, ESRD, and death. So, but however, the combination reduce more proteinuria, but overall composite outcome is not that great when you are combining AC inhibitor and angiotensin 2 receptor blocker. So KDIGO recommends avoiding any combination of AC inhibitor, angiotensin 2 receptor blocker, and direct inhibitor therapy in patients with a CKD with and without diabetes. So they are not in favor of using the combinations. So there was one controversial issue came in between, where one paper came from the Swedish network study that if you stop AC inhibitors in the late stage, advanced stage of the CKD, you can see you can delay the kidney replacement therapy, dialysis, by 8.3%. But when you stop at the same time, the 5-year mortality risk and major cardiovascular risk go up. So again, this has been thought of, probably when you take overall outcome, continuing the AC inhibitor is better. But if you are stopping this, you can just delay to some extent about the need of renal replacement therapy. Then one recent study came, Fidelio, which has been published, Fidelio DKD trials, which have been published in NEJM in 2020. They have shown again the primary composite outcome of the finerenone, which is a non-steroidal selective mineralocorticoid receptor antagonist, has reduced proteinuria, has a favorable primary composite outcomes, have favorable secondary composite outcomes in terms of the kidney failure and sustained decrease in GFR of more than 40% from the baseline. So this again has come as the new therapy, but again, because of the fear of the hyperkalemia, this has not been picked up in the practice. Let us see what happens when it comes in general practice by the physicians. Practice point, it may be reasonable to treat patients with high BP, CKD, and no albuminuria with and without diabetes with AC inhibitor or angiotensin 2 receptor blockers. Maximize dose, look for hyperkalemia, continue AC or ARB therapy unless serum creatinine rise by more than 30% within 2 to 4 weeks of following initiation of the treatment. If this goes further up, then only you should think of reducing. Or if you have either symptomatic hypertension, uncontrolled hyperkalemia despite medical treatment, or reduce uremic symptoms while treating kidney failure, eGFR of less than 15 ml per minute, if it is there. Otherwise, you should maximize the dose of the ACE inhibitor or angiotensin II receptor blocker. That is the practicing points. Diuretics, volume load always contributes to hypertension. It is many times subclinical and affects up to 50% of the people with the CKD. In non-proteolytic CKD, monotherapy with thiazide or thiazide-like diuretics like indapamide may have a role and should be considered as potential for first-line therapy. But treatment with the diuretic may also reverse the loss of physiological nocturnal dip in BP described in CKD patients. So if there is a nocturnal dip loss, you can think of using diuretics in some of the patients. Combination of the furosemide. Furosemide is a very strong and diuretics. Combining loop diuretics with thiazide is particularly powerful, and care should be taken to avoid fluid depletion, particularly in the patient of the CKD, because the CKD patients may develop acute kidney injury. And diuretics should generally be avoided in patients with polycystic kidney disease, which accelerates some cyst growth and loss of excretory function associated with their use. Calcium channel blockers. Again, calcium channel blockers, particularly dihydropyridine, that is amlodipine or nifedipine, can be used as first-line therapy in non-proteolytic CKD patient, either alone or in combination. In proteolytic CKD, their effect is similar to DAS blockade. Addition of the dihydropyridine calcium channel blocker to proteolytic patient with a standardized DAS blocker improves BP control. And so, European guidelines advocate combination therapy with an ACE inhibitor and calcium channel blocker as first-line therapy in proteolytic patients. Non-hydropyridine like verapamil has superior effect on proteinuria reductions and can also be used if the clinical situation permits. Here you can see the addition of ACE inhibitor and hydrochlorothiazide, addition of the ACE inhibitor with amlodipine, what we can see, risk reduction in normal population, overweight patient and obese, that favors benzapril and amlodipine combination can have better risk reduction. Beta blockers effectively reduce BP and CKD due to their effect on the dysregulated sympathetic nervous system. In animal studies, at least they have shown there is a reduction in the development of interstitial fibrosis. So,
Dr. Narayan, can you just little bit hasten up, Dr. Narayan?
Yeah, I'm just going to finish off. Yeah.
Okay, thank you.
So, beta blockers with the vasodilatory properties, particularly carvedilol, is very important and can be used in patients of the CKD with the dilated cardiomyopathy. Alpha blockers used efficacious as add-on therapy should not be considered as the first-line therapy. Prescription pattern, which we have seen in our own study highlighted by Dr. Manisha Sahai, has shown RAS blocker, despite being so much strong evidences for the use, only 48% of patients have these drugs in the early stages of the chronic kidney disease. We have another study in the pipeline with the eGFR decline at each stage on follow-up from the same ICKD cohort study. What we see here, at the stage 4, ACE inhibitors and ARB users, their GFR declines crosses the line. So in advanced stages, particularly in stage 4, it is possible that you might have the little higher decline in eGFR if you are using ACE inhibitors. Chronotherapy is there that advocates this one study which have shown that you can take some pills when you wake up at the night that has the better control, BP control and better cardiovascular outcomes. So that study published in the JASN has shown some of the patients of the CKD, if they wakes up that night, they can take some of the antihypertensive at the night. So to conclude, CKD patients, if they have hypertension, proteinuria, ACE inhibitor and angiotensin receptor blocker should be the first line. Low proteinuria, you can use either ACE inhibitor of angiotensin receptor blocker, calcium channel blocker, or thiazide diuretics. And as add-on therapy, always if calcium channel blocker is there, you can add on the ACE inhibitors. If the patient is on ACE inhibitor, you can add on the calcium channel blockers and subsequently other drugs. So thank you, ladies and gentlemen. Thank you for your attention.
Thank you, Dr. Narayan, for covering the topic in detail. So what we'll do is we'll go ahead with the panel discussion and take up some questions which the GPs have asked. So can you just stop sharing your screen, Dr. Narayan, so I can put up those questions? Yeah, thank you. So, yeah, so these are some of the questions asked by the general practitioners, and a panel to discuss these questions consists of Dr. Girish sir. Dr. Girish Narayan is Director of Nephrology, Udayomni Hospitals, Hyderabad. He is former head and professor of nephrology at Osmania. He has trained several DM and DNB nephrology students. He has several guest lectures and papers in national and international journals to his credit. He was scientific committee chairman of South Zone, and he has been a very popular teacher. So welcome, Girish sir, for taking out time from your busy schedule. We have Dr. Naval Chandra. He is additional professor of medicine at Nizam's Institute of Medical Sciences. He is also governing council member of National API, chairman-elect API Hyderabad chapter. He also has several guest lectures and publications to his credit. We have Dr. Manjuri. She is professor in her Department of Nephrology, Guwahati Medical College. She is a recipient of Best Paper and Poster Awards, recipient of Apsara Award 2019, recipient of Social Media Selected Best Poster Award in EDTA 2020 Milan. She has been instrumental in spreading awareness of kidney diseases in Assam, and she is a reviewer of several journals, and she has many national and international origin articles in peer-reviewed journals as well. And Dr. Uday Lal, he is the Chief Consultant Physician, Amar Hospital. He is the National Faculty Council member, Indian College of Physicians of API, and former chairman, API Hyderabad chapter. So welcome all the panel members. The first question to Dr. Girish sir. Dr. Narayan has highlighted, in your practical experience, what target of BP do you think is suitable for non-dialysis CKD patients? This is an often asked question by general practitioners. And how do you manage systolic hypertension in your elderly patients? You know, these questions have been frequently asked. Kindly answer those questions so that the general physicians are enlightened with your answers.
Thank you, Dr. Manisha. And first of all, it's very important that the so-called Women in Nephrology, the week which is going on, at this time, I am really very remember our Doyen of Nephrology, the Women Nephrology, Dr. Vidya Acharya, who was the principal, one of the founder members of the Nephrology Society, and Dr. Kumud Mehta, she was another. They struggled really hard to establish nephrology in the initial years. So in this hour of when we talk about women in nephrology, straight away these two very senior people come to our mind. I remember them for their contribution to the field of nephrology. Now I thank the organizers for giving me this opportunity to participate in this wonderful scientific session which is going on. Dr. Manisha has asked very pertinent and very important questions about the target BP. This has been a lot of debate about the so-called target BP in various. There was a time when they said age plus 10 years, your own age plus 10 years should be the systolic. But now with so many controlled trials, now we know that the target BP for all age groups remains between say 130 to 140 millimeters. But different organizations, different societies have recommended different target. Especially the Canadian Society had a very stiff target of 120 systolic, which is very difficult to achieve in most of the patients. Then the American Heart Association and the Cardiology Society in 2018 came out with the recommendation that it should be around 140. But now most of the studies do recommend that the systolic BP in non-CKD patients should be anything around 130 to 140 systolic. Yeah, so more important, especially in elderly persons, we have to assess the patient as a whole and not just go by the reading of the blood pressure. First of all, there is a problem with recording the BP with the arterial stiffness. There will be a wide pulse pressure. A very low diastolic blood pressure is sometimes recorded. The physician has to look.
I think there is a problem at Dr. Girish sir's end. So Dr. Narayan,
Yes, ma'am. His signals are showing weak, ma'am.
yeah, okay. So Dr. Narayan, can you just finish that question? I mean, suppose an elderly person comes with a blood pressure of 180/70, what would you do for that person?
Yeah. Actually, this happens because of the arterial stiffness which happens with the aging process. And so once the arterial stiffness, artery becomes stiff, systolic blood pressure go up and diastolic pressure go down because of the elastic recoil of the blood vessels walls go off. What happens, we should see sometimes the diastolic pressure is so low, and at least the KDO guidelines this time has recommended if this goes below 50, where the coronary perfusion becomes the problem. So you should avoid if your diastolic blood pressure is going too low. So that should always be keep in mind. It should not go below 50 or that kind of things, and the patient stays the KD. And definitely the systolic blood pressure is also equally bad. So you should try to control and bring down to the recommended level, particularly if the patient tolerates. This all depends on the how much blood pressure you have to individualize, how much blood pressure your patient is going to tolerate, and try to bring down as 140, as most of the systolic blood pressure recommendations is coming back. If the patient has already the CKD, the patient's the degree of protrudia and other problems, all guides on. So at least if the patient tolerates, you should bring down to the 140. So that is the aim, and preferably calcium channel blockers are usually thought to be one of the very good drugs for this group of the patients.
Thank you. Thank you for taking up those questions. So Dr. Naval, are you there? Fine. So I think this question was discussed. Which apparatus would you suggest for home BP monitoring? Dr. Naval? Yeah.
Yeah, good evening, and I firstly congratulate Dr. Manisha for having a wonderful session going, and especially wishing you on the occasion of World Women's Day. I think you are a very apt example for a very leading woman in our circles, and I congratulate you wholly for conducting such a wonderful program. So coming firstly to which apparatus would you suggest for home BP monitoring? Yeah, we've come a long way right from, our grandfather's days where we used to talk so much about the mercury thermometer apparatuses, which were found to be so accurate. And we've come up those days when we have learned that these have been the most accurate BP apparatuses. And so much so I still have one in my clinic. But a lot of data now coming in, a lot of meta-analysis, in fact, publications in JAMA and other international journals now recommending the use of any of these automatic or automated BP apparatuses like Omron or one from iHealth or so forth. So, and ideally at home now for BP monitoring, I would suggest to go with one of these automated BP apparatuses like Omron and so forth. And
what about the second question? Are there other BP apparatuses available now? The ones which measure thrice and all that, do you recommend those?
Yeah, those are pretty accurate. In fact, they give you a mean reading of the, your blood pressures, and pretty ideal for home monitoring, and very much more accurate. Though studies are showing that there's a 5% difference and so forth, but I think what apparatuses you're getting these days are pretty accurate, and I think we can go ahead with those for our day-to-day home BP monitoring related issues.
Okay. The general practitioners also want to know from you which calcium blockers do you prefer and why? For a CKD, for instance, what would you be using?
We've come a long way. I mean, you're getting, you're loaded with calcium channel blockers in the market. Every other month, we're having a release of one calcium channel blockers or the other. But primarily, they're majorly divided into two groups. One is the dihydropyridine calcium channel blockers, and one, the non-dihydropyridine. So in such situations where you have a CKD situation in hypertensive and CKD, definitely I would prefer one of these, non-dihydropyridine calcium channel blockers like verapamil or probably diltiazem. compared to the other, dihydropyridine calcium channel blockers, primarily with the reason that, the proteinuria has definitely comes down much more with these non-dihydropyridine calcium channel blockers than those with, the dihydropyridine calcium channel blockers.
So one message would be that if you are using them for proteinuric CKD, you can combine it with ACE inhibitors, the dihydropyridine channel blockers. You can combine them that with RAS blockade as well.
Yes.
So that's what you mean to say. Okay. So coming to the next panel member, Dr. Manjuri. This is a frequently asked question, and the GPs want to know till what level of creatinine should we use ACE inhibitors or ARBs, and when should we stop them? And what's the maximum dose of telmisartan, losartan, enalapril, and ramipral which you prescribe?
Yeah. Can you hear me, Dr. Manisha?
Yeah, yes.
Am I audible?
Yes.
Yeah.
You are.
So, let me first answer the first question. Till what level of creatinine should we use ACE inhibitor and ARB? First of all, let us make it very clear that we stage the CKD as per the eGFR and not according to serum creatinine, which is just a very insignificant marker of CKD. So as per your presentation, you mentioned about the formula which is regularly used by all the nephrologists, that is the CKD EPI, and in this equation we can know the various stages of CKD. So from the first talk, from your talk to Dr. Narayan's talk, everybody has been mentioning about the use of ACE inhibitors and ARB in all the presentation. So as per the KDOQI guidelines, Dr. Narayan has mentioned about the KDOQI guidelines, the recent one that was published in 2021, which has come out in 2021, they recommend starting ACE inhibitor and ARB to people with high BP, CKD, and severely increased albuminuria. That means CKD stages from G1 to G4 with albuminuria of 3A3. That is when the urine ACR is more than 300 milligram per gram per day. They also suggest in all patients without diabetes. That's a very significant and important guideline for us. The second guideline they have suggested, we should start ACE inhibitors and ARBs to people with high BP, CKD, and moderately increased albuminuria. That is CKD from stage 1 to G1 to G4, albuminuria of 8-2 without diabetes. And they recommend starting ACE inhibitors, ARBs to people with high blood pressure, CKD, and moderately to severely increased albuminuria in all diabetic patients. So these ACE inhibitors and ARBs are the first line of drugs for treating hypertension and CKD, and the role of ACE inhibitors and ARBs has been well established.
But when would you stop them? When would you stop them, Dr. Manjula? Like what level of
Dr. Narayan has mentioned in slide. If there is a jump of creatinine of more than 30% from the baseline, then you have to stop ACE inhibitor ARB. When the hyperkalemia is persistent, there are a lot of newer drugs to control hyperkalemia. So there are a lot of suggestions and recommendations. And even if starting ARB and ACE inhibitor, there's hyperkalemia, and you try to cut down on the dose of the ACE inhibitor or ARBs and try to control hyperkalemia by the available medications like the calcium, the potassium binders, the newer ones like paclitaxel and the sodium zirconium, these things, then if even in spite of using these medications, hyperkalemia is not controlled, then we have to stop your ACE inhibitors and ARBs. And to take on with the second question, yes, the maximum dose of these medications which we can use. So when we talk about, first is your telmisartan. The tablets which we get in the market are in the strength of 20 mg, 40 mg, and 80 mg. For telmisartan, you again start off with the lowest possible dose, which the patient can tolerate. As per his tolerability, you can increase the dose and you can go up to a maximum of 80. I don't go beyond 80. Again, for your losartan, we get in the strength of 25 mg, 50 mg, even 100 mg. You start with 25, try to titrate the dose. BP is still not controlled. You can increase up to the maximum tolerated dose of 100 milligram. For enalapril, we get in the strength of 2.5, 5, and 10, right? So you can start with 2.5 mg and can go to a maximum of 40 mg. But then we have to be very careful about seeing the hyperkalemia status keep on checking the blood potassium, and also keep on checking the creatinine. And about the Remipril, yes, again, we get the tablets in the strength of 1.25, 2.5, 5 mg, 10 mg. You can start with the lowest dose of 1.25 and keep on titrating, but you can go up to a strength of 20 mg. But for all these ACE inhibitors in ARBs, we have to keep in mind about the persistent hyperkalemia and a jump of serum creatinine of more than 30% from the baseline from where we started these medications.
Dr. Manisha? Well, your connection is poor.
Yeah, thank you. So I think there was some problem with the internet connection my side. So thank you, Dr. Manjari, for that answer. So I think you have clearly explained that.
Yeah.
So,
Dr. Manisha.
yes.
Yeah, one small a point I wanted to make it here was, especially for elderly persons, the combination of diuretics and the various drugs which are used, we have to be really very careful about using drugs like hydrochlorothiazide, which is a standard recommendation for all antihypertensives. But we see so many cases of hyponatremia presenting into the casualty with history of frequent falls in the elderly persons. So a fixed dose combination of diuretic and other antihypertensives preferably should be avoided in elderly people, especially over 80 years. And our usual suggestion is the diuretic to be used under close supervision, and the dose can be titrated depending upon the individual patient's requirement, other comorbidities like congestive cardiac failure and other conditions, and then it can be given as an independent drug instead of a fixed dose combination and landing up with hyponatremia and complications of diuretic use. So
the point is well taken, sir. I mean, that's quite usual scenario, especially with thiazide diuretics, very commonly seen. So thank you for bringing out that point. So Dr. Uday, in your practice, what do you do when you initiate the therapy of hypertension with a single drug, or you prefer drug combinations in CKD? And how frequently do you use spironolactone in your practice in management of CKD hypertension? As a physician, what is your opinion on this?
Thanks first, Manisha, for inviting me for this program. I think it's a great initiative that you've taken up and highlighting the incidence of CKD in our country, which is going to be, it is humongous, and we really need to take urgent steps on that. And of course, you gave, as usual, a brilliant talk. And I'd like to take this opportunity to just wish all the women happy Women's Day who are on this forum. And I think that Dr. Narayan Prasad gave a pretty elaborate talk. Coming to the question about initiating therapy of hypertension, whether you use a single or a double drug, I think that would depend really as to what stage of CKD you're treating. If it's the early stage, stage 1 or stage 2, and there's no resistant hypertension, you could even start with one drug and monitor them. Though the ESC guidelines, hypertension European guidelines say that patients with CKD, you generally need to start with 2 drugs, but I think it would really depend. You need to take an individual take on that, depending if what are the other comorbidities that are there with the patient, if he's a diabetic or in addition, and or there is some heart failure, etc. So those are things that you would have to consider. So I don't think there is any one correct answer to say that you can start with a single drug or a drug combination. You would have to take the patient as a total before deciding that, you know, in total, the various other problems that the patient may encounter. Yes, we need to definitely keep the hypertension under control in CKD, because we know that that will prevent the further progression of the disease. So that should be the first criteria. So blood pressure monitoring, I think by and large is a rule, you know, if you can keep the blood pressure down to less than 130/80, that would be a target, especially with people with comorbid conditions like diabetes, etc. If there are no comorbid conditions and there's CKD, probably even 140/90. But I would probably still like to aim at 130/80 or 130/85 as a blood pressure. Okay. And moving on to your the second question about spironolactone in management of hypertension. Again, you would probably use it in cases where in CKD where there are patients who are with heart failure. Definitely, we know it has an effect on both the systolic and the diastolic dysfunction. But we need to be careful because it can cause hyperkalemia. I think we have a lot more agents available in our armamentarium that if patient has heart failure that we can use. Suppose a patient, whether it's diabetic or non-diabetic, you could use an SGLT2 inhibitor, for example, if somebody has heart failure. But spironolactone, I would be a little guarded about using it but of course, I would use it as probably the fourth agent in resistant hypertension if I need to use it.
Yeah, thank you, Dr. Uday, for your very pertinent comments, and thank you for those insights. So I think we'll move over to the last topic of this session, which is again a very important topic. We'll be talking about painkillers in CKD, a practical approach. What would a nephrologist be telling the general physicians and the practitioners? What to use, what not to use? Because whatever we may say, some patients do need painkillers. So this will be delivered by none other than Dr. Edwin Fernando. He is a professor and head of nephrology of Government Stanley Medical College, Chennai. And he is an ISN fellow in nephrology. He also holds fellowship of Royal College of Physicians, Glasgow, UK. He is also a member of Royal College of Physicians, Edinburgh. He is member of International Society of Nephrology, South Asia Regional Board, member Renal Transplant Advisory Committee, Government of Tamil Nadu. He is a member of Board of Higher Specialities, Dr. TNMGR Medical University, member Scientific Committee, Indian Society of Nephrology, Ethics Committee, Government Stanley Medical College, Academic Advisor, Government Stanley Medical College. He was a principal investigator at site for Credence and DAPA CKD trials, and he received Award of Excellence from the Government of Tamil Nadu in 2018, 2019, 2020, 2021, and probably 22 is also awaited. Special interest, transplantation, renal disease in pregnancy, AKI, 90 publications in index journals, 4 books and 200 invited talks. And he is a reviewer for many journals. So over to you, Dr. Edwin, for your practice pearls on painkillers and CKD.
Thank you, Manisha. Thank you for inviting me, and a great initiative by the women in just a minute.
What happened, Dr. Edwin? Any problem? Yeah, we can, yeah.
See my slides?
No, not able to see.
Sir, actually, you must have selected the screen.
Yeah.
Sir, just click on share screen, and then if the presentation option is there, you have to select that, sir.
Go to the whiteboard or?
No, sir.
No, sir.
Sir, you can select the screen itself. Yes. If PPT option is not showing, then select the screen, then we can guide.
Yeah, I got it now. Can you see it now?
No, sir.
Yes.
Yes, sir. Now we got, sir, right?
Yes.
Yes. Right. Sorry about that confusion, and a great initiative by the Women in Nephrology group. Thank you, Manisha, for inviting me. I shall be talking briefly on pain management in chronic kidney disease. Pain is common in patients with advanced CKD. More than 50% of patients report moderate or severe pain, whether treated with dialysis or managed conservatively. Pain is a multi-dimensional phenomenon with physical and psychosocial components, and the management of pain can be pharmacological or non-pharmacological. What are the challenges a nephrologist faces, and what are the challenges, again, a family physician would face when dealing with pain in renal failure patients? A systematic review showed that nearly about 80% of ESRD patients with significant pain were not prescribed analgesics. Now, what are the factors? One is failure to seek medical attention at the appropriate time by the patient until the pain is very disabling, fear of addiction to opioids, wrong perception of adverse effects being caused by analgesics are the major reasons for suboptimal pain control. The other challenges being the altered pharmacokinetics of analgesics in ESRD patients, major impediment causing drug toxicity, unfavorable effects, elderly patients with higher burden of comorbidities and polypharmacy, making it difficult to effectively treat pain. And more importantly, a lack of training among the nephrologists in pain management, failure to acknowledge the extent and severity of the problem. Now, what are the key considerations in the evaluation of pain? First, we have to see what is the type of pain, then the chronicity and the possible reversible causes of pain, then the intensity of pain, and then what are our treatment goals. Pain in CKD can be broadly classified as dialysis-related, non-dialysis related. So muscular cramps, pruritus, AV fistula pain, puncture pain, headaches, injection of erythropoietin, PD fluid installation, intestinal cardiac ischemic pain during dialysis, and non-dialysis related pain mainly related to osteoarthrosis, osteoporosis, renal osteodystrophy, peripheral neuropathy, peripheral vascular disease, polycystic kidney disease, calciphylaxis, and malignancy. Now, what is acute pain? Acute pain is typically persisting for less than 3 months, associated with tissue damage, usually episodic with periods without pain, and tends to respond well to pharmacological therapy. Then we have acute intermittent pain. This is acute pain from tissue injury may occur over long periods of time. Pain from needling fistulas, the intradialytic Steele syndrome, headaches, and cramps. And chronic pain is any painful condition that persists for more than 3 months, usually initiated by tissue injury, but perpetuated by neurophysiological changes, leading to continuation of pains even after the healing has happened. This results in functional impairment and disability and may not well respond to analgesics, including opioids. So basically, we deal with 2 types of pain. One is the neuropathic pain, other is the nociceptive pain. So what is nociceptive pain? This results from tissue damage in the skin, muscle, and other tissues, causing stimulation of sensory receptors. So this is often felt at the site of damage. Somebody has a knee joint pain from dialysis-related arthropathy, and this tends to respond to analgesics. On the other hand, neuropathic pain is a little more painful, results from damage to the nerve system, resulting in either dysfunction or pathological change. It felt at a site distant from its cause. That's example, distribution of a nerve. The common descriptions being burning, shooting, electric shock, like etc. The presence of allodynia, pathognomonic. A patient won't even allow to touch you. Responds poorly to analgesics. Typically requires adjuvant therapy such as anticonvulsants like gabapentinoids or carbamazepine and tricyclic antidepressants. So the pain assessment goes according to this PQRST assessment tool. P is what makes you hurt. There is precipitating factors. Number 2, Q is the quality of pain. How intense is the pain? R is the pain referred. Does it radiate? S is how bad is the pain, severity and the site. And when does the pain occur? Timing. So this is called the PQRST scale, pain assessment tool. And we are all familiar with these smileys, the Wong-Baker faces pain rating scale. So this again tells us the pain measurement scale. You will find this on any chart in any emergency room, how to classify the pain to understand the intensity. Coming to use of NSAIDs. Now, NSAIDs should be minimized among patients with CKD stage 3, avoided in 4 and 5, especially with those with residual renal function or kidney transplant recipients, regardless of the CKD stage. NSAIDs induce relatively low renal hemodynamic compromise, include Salindac and salsalate. These two have relative preservation of renal prostaglandin synthesis, and salsalate has weak prostaglandin inhibition at therapeutic doses. Salindac is available in India. I'm not sure whether salsalate is available with us. While prescribing NSAIDs, make sure you optimize volume status and cardiac function, reduce frequency of administration, avoid concurrent use of inhibitors of the RAS system to prevent synergistic reduction in GFR. Short-acting ones are preferred over the long-acting agents. The risk profile is well known to you. We have the GI toxicity, we have the cardiovascular effects, thrombotic events, myocardial infarction. Long-term use of NSAIDs increase the risk of stroke by 64%. And then, of course, we're all aware of the nephrotoxicity, loss of residual renal function, sodium water retention, can aggravate hypertension, hyperkalemia, can cause nephrotic syndrome, type 4 RTA, and tubulointerstitial nephritis. Now, this column, this table shows the nephrotoxicity in different stages. And if you look at stage 5 CKD, what it can cause, the risks that is caused. So stage 5 CKD, you find that the risk is extremely high, while you have to use it very carefully in 1 and 2, where the risk is similar to general population with reference to AKI, hyperkalemia, hyponatremia, hypervolemia, hypertension, progression of CKD, etc. So one has to be careful after stage 4. In, again, the potential NSAID nephrotoxicity in CKD, if you look at the recommendation, the weak recommendation is it absolutely contraindicated except under circumstances of palliative care? Again, short-term use of less than 5 days is acceptable. Long-term use also acceptable on a case-to-case basis with close monitoring for nephrotoxicity and for development of other risk factors. Now coming to adjuvants. So the recommended adjuvants for the treatment of neuropathic pain are gabapentin, pregabalin, carbamazepine, amitriptyline, and ketamine. So these are the gabapentinoids. We have gabapentin and pregabalin. Both are analog of neurotransmitter GABA. Pregabalin, in addition to analgesic anxiolytic, has an anticonvulsant and anxiolytic property. Dose reduction needs to be done in renal failure. Both are well dialyzed. Both have to be dosed post-HD. So the dose of gabapentin can be 100 mg post-dialysis or 100 mg every second night. With pregabalin, you have to be a little more modest with your doses of 25 milligrams or 25 milligrams every alternate day with CKD stage 5. Tricyclic antidepressants are effective but less well tolerated than the gabapentinoids because of its anticholinergic, histaminergic, and adrenergic side effects. So this results in dry mouth, orthostatic hypotension, somnolence. Generally, dose reduction is not required. Patients with CKD will often respond to lower doses, but one has to be careful with the other side effects. Ketamine is a very effective analgesic in sub-anesthetic doses. It's a potent NMDA receptor channel antagonist, typically reserved for intractable neuropathic pain resistant to opioids and other adjuvants. Example like calciphylaxis, no dose reduction in CKD. It can be given oral, IV, or even subcutaneous. Now coming to opioids. Opioids in CKD, there's accumulation of renally excreted opioids and their toxic metabolites, so that's the concern. There can be potentially life-threatening neurological complications like severe oversedation, myoclonus, seizures, etc. Clinically significant suppression of respiratory drive event, worsening of kidney function because of opioid-induced hypotension, renal hypoperfusion, urinary retention, hyperkalemia with opioid-induced severe constipation. These are the concerns. So the WHO has classified weak opioids as codeine and tramadol, and strong opioids like morphine, fentanyl, pethidine, oxycodone, hydromorphone, methadone, etc. Dose reduction is required for most opioids among CKD patients. Methadone and fentanyl may be acceptable in CKD patients. Okay, these are the opioid safety that I mentioned. Fentanyl, alfentanyl, both are safe. Morphine is preferably to be avoided, and codeine is to be avoided. Oxycodone, we don't have enough evidence. In chronic pain of CKD, opioids are used where the site of action in the primary afferent fiber, that is the nociception. In the presynaptic area, it blocks the calcium channel, and postsynaptic blocks inward rectifying potassium channel. So the effect is hyperpolarization, halting propagation of pain signal. So this is how they act. And these are the weak and strong opioids that I mentioned. So which are the ones that are safe to use in CKD? Buprenorphine is available, transdermal patch. Indication is severe chronic pain. No dosage requirement is required and not removed by hemodialysis, no dose adjustment. Fentanyl, again a transdermal patch. Again, indication is severe chronic pain, safer profile, no clinically significant accumulation in CKD. And clearance depends on the filter, flow rate, etc. Could be absorbed by certain dialysis membranes. So these are the ones that to be used with caution, and do not use morphine and codeine, definitely not to be used. The side effects are too well known to you: nausea, vomiting, constipation, dizziness, somnolence, retention of urine, dry mouth. It affects the bone mineral density. It inhibits the HPA axis, so there could be androgen deficiency. And in HD patients, because of increased risk of falls, fractures, altered mental status, and what is most worrying is addiction. And treatment of opioid constipation can be with laxatives and methyl naltrexone. So this is the WHO analgesic ladder for CKD. How do you use it? You begin with a non-opioid analgesic plus or minus adjuvant analgesic. Step one will be to use weak opioids, non-opioid analgesics, and then adjuvants. In step two, where the moderate to severe pain is there, moderate pain is there, strong opioids. And in step three, you have to look at very strong opioids, etc. So we have to select patients. We have to regularly assess access to expert advice prescribed by competent doctors. So what is the correct dose? The lowest possible dose for the patient is a correct dose. Clear treatment goals and agreement with the patient. Close ongoing patient supervision, reassess benefits and risks. Taper down and discontinue if risks outweigh the benefits. Patient education on safe use, patient awareness regarding potential for misuse, especially the opioids, abuse and addiction. Monitor signs of addictive behavior and to be dispensed by competent pharmacists. Tramadol is something that's very commonly used in our emergency room and whenever we see CKD patients in pain. It's a weak synthetic opioid related to codeine, extensively metabolized in the liver. Both parent drug and active metabolite, M1, contribute to the analgesic effect through the mu opioid receptors and non-opioid mechanisms, inhibition of serotonin, norepinephrine uptake, etc. When the GFR is less than 30, tramadol and its metabolites can accumulate. Maximum dose of tramadol in advanced CKD not to exceed 100 mg twice daily and 50 mg twice daily for dialysis patients. Watch for serotonin syndrome, which is one of the potentially life-threatening syndrome that may occur with the use of tramadol, especially when it is combined with other antidepressants and other drugs that impair the CYP3A4 metabolism are used concurrently with these patients. They can have mydriasis, diaphoresis, agitation, increased bowel sounds, diarrhea, autonomic instability, clonus, tremors, etc. Morphine is something again which we used to use earlier for patients with pulmonary edema before we mobilized them to the dialysis room. It's metabolized primarily to active metabolite M3G and M6G. So this M3G lacks analgesic effect, may have neuroexcitatory effects, contributing to the adverse effects like allodynia, myoclonus, and seizures. M6G has a potential analgesic effect more so than morphine. So though M6G is dialyzed, it diffuses out of the CNS slowly, may not be completely removed during dialysis. Both these metabolites can accumulate in renal failure. There is a poor, inconsistent correlation between the plasma levels of morphine and its metabolites and clinical efficacy or adverse effects. So one has to be extremely careful, if maximum not use it. Or weak opioids better than strong opioids in CKD. Weak opioids have dose-dependent adverse effects similar to strong opioids. There's a recent study of about 150,000 patients on dialysis. Highest hazards for altered mental status, falls, and fractures among all opioids prescribed were associated with codeine. That's why codeine has been contraindicated. No evidence that at an equivalent analgesic efficacy, weak opioids carry a lower risk of addiction than low-dose strong opioids. So given the risk of using weak opioids, codeine and tramadol in patients with advanced CKD seems more prudent to use to a strong opioid at a low dose with careful titration when opioid therapy is required. This is a topical non-opioid analgesics, acetaminophen, capsaicin, lidocaine, topical NSAIDs. Some oral NSAIDs can be used. And we have the opioid medications, which are topical buprenorphine patch, fentanyl patch, the oxycodone and hydrocodone releases, methadone and tramadol immediate release. So these could also be used topically. So CKD management, according to this publisher, this published by Davison et al., trial each step for 1 to 4 weeks before progressing, depending upon the pain severity. Start with adjuvant therapy. If pain persists, add non-opioid plus or minus adjuvant therapy. If the pain persists, add strong opioid plus or minus adjuvant therapy. Titrate slowly as tolerated to adequate pain relief. So what is the first line? Gabapentin. Second line is carbamazepine. Third line, of course, is to use tricyclic antidepressants. Acetaminophen, maximum of 3 grams daily in addition to adjuvant therapy. Adjuvant can be stopped if no benefit or not tolerated. Hydromorphone subcutaneously, or you can consider using buprenorphine, fentanyl, or methadone. Again, for nociceptive pain, acetaminophen, consider a topical NSAID, diclofenac gel, or hydromorphone starting subcutaneous dose. Also consider buprenorphine, fentanyl, and methadone. So we are caught between 3 areas: the system, the provider, and the patient. Now, the patient has got multiple problems: multifactorial etiologies, types of pain, altered pain perceptions, coexisting psychosocial illness, fear of addiction to opioids, limited non-dialysis time, polypharmacy, etc. As a provider, we have lack of nephrologist training, lack of nephrologist ownership of pain management. We forget that they are our patients. Unfamiliarity with the safety, efficacy, and dialyzability of medications, and hesitancy to prescribe opioids. Then you have the system that has got fragmented care, especially in our country, lack of quality incentive, lack of evidence and guidelines, and limited access to non-pharmacological options. So to conclude, let me say that all medical providers have moral and ethical obligation to ease their patient suffering by treating their pain. Managing pain in the setting of kidney disease is a challenge for providers. Pain experienced by this patient population is often inadequately managed. Working knowledge of current pharmacology and adjunctive therapies is mandatory. It is imperative to highlight to the patient that absolute resolution of pain symptoms is not our goal, and it may not be possible. We aim to achieve at least a 30% reduction in pain intensity, and that is clinically significant. Multimodal pain management strategy is the best. Thank you very much for the patient listening.
Thank you, Dr. Edwin. That was a very crystal clear lecture with lots of messages and useful practical tips as well. So thank you for those really great points. So now I think we'll move over to the panel, which is associated with this topic, the pain management in CKD patients, the painkillers. So we have eminent panel members on this panel. Dr. Anuradha Raman, she is Director and Head of Nephrology, Sunshine Hospital, Hyderabad. Madam is former Professor and Head Nephrology, Usmania General Hospital, Hyderabad. She was the past President of ISN, Indian Society of Nephrology. She is recipient of APJ Abdul Kalam Award. She is a Scientific Committee Chairman of ISN South Zone. She has several guest lectures and papers to her credit. She has trained several DM and DNB students in nephrology. She is also incidentally the patron of Women in Nephrology India, and she is one of the very popular teachers in the state of Telangana as well as in India. We have Dr. M. Raja Rao. He is Superintendent Gandhi Hospital, Professor of Medicine, Gandhi Hospital. He was the COVID in charge for Telangana, where he rendered Herculean service. He has many awards, guest lectures, and publications to his credit. Dr. Sonal Dalal, she is consultant nephrologist and transplant physician and director of Gujarat Kidney Foundation, Ahmedabad, Gujarat. She has a teaching experience of more than 25 years in nephrology. She has more than 20 publications, international and national. She was a secretary of Nephrology Forum, Ahmedabad, and she is the head of Department Nephrology, Sterling Hospital, Ahmedabad. And last but not the least, we have Dr. Georgie Abraham. Sir is one of the very eminent members of nephrology committee in our country. He is professor and senior consultant nephrology, MGM Healthcare, Chennai. He is retired professor of medicine, Pondicherry Institute of Medical Sciences, director of nephrology, Madras Medical Mission Hospital, Chennai, founder president of Peritoneal Dialysis Society of India. He has received several international awards. He is a recipient of International Distinguished Medal in Nephrology 2003, American Kidney Foundation, first recipient of International Society for Peritoneal Dialysis, Oriopolis Award for lifetime contribution to peritoneal dialysis, ISN Roscoe Robinson Award in 2015 for excellence in education of nephrology and medicine, and Oriopolis Canadian Society of Nephrology Baxter Memorial Award, award from His Excellency Sri Siri Sena, President of Sri Lanka, on the inauguration of ISN Gardner CKDU Fund. International PACES Champion Award 2017 for outstanding contribution to the development of MRCP PACES examination in South Asia since 2007 by Royal College of Physicians of London, Glasgow, and Royal College of Physicians of Edinburgh. He is adjunct professor IIT Chennai, and he is also executive member World Kidney Day and founder trustee Tanker Foundation. So he has many more laurels and awards to his credit. So I think we'll now go over to the question answer session. First question from the general practitioners to Dr. Anuradha ma'am. What can be done to increase awareness about painkillers in CKD? Which painkillers would you prescribe for patients with kidney disease? CKD stage 1, like GPs when they want to prescribe for CKD patients? And do you think the over-the-counter sales of NSAIDs should be completely banned? So what's your opinion on this? The GP wants to know from you, stage 1 or 2 CKD, what painkillers are safe to use?
Thank you, Manisha. Am I audible?
Yes, ma'am, you are audible.
Yeah, thank you, Manisha, for an excellent program and for inviting me to be a part of this meeting. Edwin has dealt extensively with NSAIDs in CKD, but coming to practical points, you want to know what can be done to increase the awareness about painkillers and CKD. We as nephrologists are very, very scared if somebody prescribes NSAIDs. And we know that at least about 5 to 7% of hospital admissions are due to drug-related side effects, and among them about 10 to 15 are due to NSAID-induced either cardiovascular or gastrointestinal or renal side effects. As the mechanism, as a rule, I would be very hesitant to use NSAIDs in any stage of CKD, because we know that as the kidney disease progresses, the GFR is maintained mostly by the afferent arteriolar dilatation, which is NSAID related. And if you, prostaglandin related, and if you give NSAIDs at this point, you're going to cause a worsening of CKD. NSAIDs as such can also cause AKI, and mostly it is hemodynamic mediated AKI. They can also cause acute interstitial nephritis. They can present as a nephrotic syndrome. Coming to which class, because the mechanism of action is almost the same for all class of NSAIDs, be it selective or non-selective, it's very difficult to say which is a safe NSAID to use. Earlier, it was thought that Solindac is probably renal safe, but it's not available in India. But as far as NSAIDs go, all NSAIDs are to be avoided. If we need to know which NSAID can be used, at least for pain management, probably acetaminophen which is what you call as the in abroad it's used, it is, I don't get the name, or probably Motrin they use, but when you give any NSAID, we should be careful in monitoring the renal functions, especially at all levels of renal failure, even at end-stage renal failure, because apart from causing AKI, they have other effects, like they can cause severe hyperkalemia, they can have hyponatremia, they can very rarely in patients who have, they can cause papillary necrosis. So we need to be very, very careful in using NSAIDs in any stage of renal failure. How to, how do we get the message onto the public? That's what you wanted me to tell. But I mean, I have been thinking how this should reach the general public, that NSAIDs are bad, and what can be done. If you go and sit, I mean, it's long time that you have gone and you are sitting in theaters to watch movies, but even if you switch on the TV nowadays, all of us see on TV, you know that there is a lot of awareness about cancer lung by smoking and its relationship to cancer lung. So likewise, I think we can have something to say that NSAIDs can damage not only the kidneys, but have their effects on the cardiovascular system, on the gastrointestinal system. So NSAIDs in any form is bad, and it should be avoided as far as possible. So for then the next question would arise, then what is, if the pain is severe, what do you use? Probably tramadol is reasonably okay, because it causes, apart from where there is inflammation, if for pain management, tramadol can be a good alternative. Plain paracetamol can be used. And if NSAIDs need to be used because the pain is because of an underlying inflammation, I think we should not use it for more than a week. And then we need to keep monitoring the renal functions. Should the over-the-counter sale of NSAIDs be banned? I think, in my opinion, yes, because at least there should be a prescription apart from paracetamol. If you need to buy any NSAID, I think, like in the West, it should be on a prescription. Otherwise, over-the-counter sale, you go to any medical shop and tell the medical fellow, I have pain. The first thing he's giving is an NSAID. And I have seen a lot of prescriptions when patients come to us with renal failure, and we ask them, we probe, and then get some prescriptions from them. And sure enough, there is either an NSAID injection or a tablet. So I think it should be dispensed only with a prescription, and over-the-counter sale of NSAIDs should be banned.
Yeah. So very well said, ma'am. I think you have brought out most of the important points. Use it only if absolutely necessary. Otherwise, should not be the drug of first choice. You have many other options, which Dr. Edwin has also shown. So,
Manisha, just a small point.
Yes.
You had mentioned NSAID should be banned from over-the-counter prescription. I think any drug should be banned.
Yeah. Okay. Okay, I stand corrected. I think that's true.
No, but I mean, NSAID specifically, because we are talking today of painkillers, that I think that's why she put that question. But for that matter, any drug which is should be on a prescription. Yes.
Absolutely right. So I think Dr. Raja Rao will not be joining us because he is unfortunately in his village with poor connectivity, and he's has gone there for his father's ceremony. So he has just sent a message. So yeah, Dr. Sonal. So what we can do is we can take Dr. Raja Rao.
And if there is any other API member here.
Yeah. So yes, we'll just come back to Dr. Raja Rao's questions, ma'am, with the other API members. So Dr. Sonal, what medicine would you advise for kidney patients with leg cramps, which they so often complain during dialysis? And Madam has spoken about NSAIDs, the oral intake to analgesic creams containing these drugs also cause kidney damage?
Yes, Dr. Manisha, thanks for the this opportunity. As far as the question is, what about the medicine which we give for the patients who are having leg cramps, patients who are mainly on the dialysis? Usually when patients who are on dialysis, they have restless leg syndromes, they have very pain, which is sometimes related to dialysis or without dialysis. Usually what we recommend is for the cramps is we can tell patient that he can do stretchings, some muscle stretching exercises. If he's been sitting quite long without doing anything, he can do some walk around, and if that can solve his problem. Better to avoid alcohol and caffeine. That is what we should recommend to our patients when they get these repeated cramps. Simple leg massage or hot and cold fermentation also sometimes solves the problems, and we don't need to give medication if that is solves the problem. During dialysis, they should have minimization of intradialysis weight gain. More the weight removal we do, more if more than 3 kg of weight is removed at a time, patient can get severe cramps and other things. So intradialysis weight gain is to be kept below 2.5 kg. That would solve sometimes the cramps. If we can increase the dialysate sodium, that also sometimes helps in reducing the cramps in patients who are on dialysis. Certain vitamins like vitamin E, biotin also helps. If patient is on dialysis for long term, L-carnitine would help. And of course, if they have pain in spite of all the conservative treatment, as Dr. Fernando said, we can use tricyclic antidepressants, or we can use gabapentin. Gabapentin works very good in these patients, only because patients of renal failure, they don't excrete gabapentin well, so we have to reduce the dose to 100 milligrams, or if it is we are giving pregabalin, it is 25 milligrams, or in sometimes 25 milligram alternate day, and that is sufficient to relieve the pain. The second part of your question, which I can see, is whether we can use analgesic creams. Analgesic creams, like if you have a diclofenac cream, that also can get absorbed. Even eye drops, that also can get absorbed. So unnecessary overuse of these local applications to be avoided. We have substitutes like menthol or some sensor oil or something like that. So better to avoid analgesic use. And even if we use, the amount of like it should be less than 5 to 10 grams is what we should advise to the patient. Thank you.
Yeah, thank you, Dr. Sonal, for those nice answers. You have clarified the issue. So now moving over to Dr. Georgie, sir. I mean, can a single dose of NSAID cause kidney failure, or is it dose dependent? Can we give NSAID in a normal person? Can we give diclofenac in a normal person? Can a single dose also cause kidney failure? And what advice would you give as a nephrologist to reduce nephrotoxicity of painkillers in those who really need it for pain relief? Example, patients with fractures. So over to you, Georgie, sir, and thank you for being here. Siddharth, can you unmute Dr. Georgie? Siddharth, can you unmute Dr. Georgie? I think Dr. Georgie has sent a message that he is not able to unmute from his end. So I can't unmute you, so you have to press that unmute button. I'm not able to unmute you. Hello?
Yes, ma'am.
Yes, Siddharth, just unmute Dr. Georgie once.
Okay. Dr. Georgie, now you can select.
So you have to unmute from your end.
I sent you unmute request. Dr. Georgie, are you there?
Okay.
How about now? Can you hear me?
Yes, sir. We can hear you.
Okay.
Please go ahead.
Okay. Thank you, Manisha. In patients with chronic kidney disease, over stage 2, we should not be using NSAID. Can single dose produce kidney failure? Yes, in patients who have severe cardiac failure, hypovolemia, and also pre-renal failure, a single dose may lead to acute kidney injury, which is probably related to hemodynamic changes and lead to an AKI. Now, the kidney has 4 compartments: blood vessel compartment, glomerular compartment, tubular and interstitial compartment. All compartments of the kidney can be involved due to NSAID. The best and probably the safe NSAID use is those ones with a half-life of less than 4 hours, because those with a shorter half-life, they produce less damage to the blood vessels and the nephron as well. So probably diclofenac may be one of the agents which may be used. And regarding, I just wanted to add to the previous opinion leader, quinine sulfate is one of the drugs which can be used in those who get cramps regularly during dialysis, in spite of adjusting their intradialytic weight gain. And we have used that, and this is being given 1 hour prior to dialysis. And so there is no safety for NSAID as such. NSAID can give rise to glomerular changes, which are minimal change disease, rarely membranous disease, and tubulointerstitial disease, which are acute tubulointerstitial nephritis. So one has to be extremely careful while using NSAID in those patients with hypertension, because it can lead to worsening of hypertension as well as hyperkalemia. So unless you use NSAID for a long time in patients with normal renal function, you do not develop renal failure, especially related to tubulointerstitial nephritis or minimal change disease. I am sure that I have answered the question.
Yeah, thank you. Thank you very much, sir. Thank you for joining in, and thank you for those answers. So, Dr. Sriram, can you take up Dr. Rajarao's questions? He has messaged that he's unable to join. So, what pain management strategies would you suggest for GPs to use for their patients for chronic pain management? I think Dr. Edwin covered this very nicely. As a physician, what do you do in your practice to reduce chronic pain management, especially in patients who have impaired renal function?
Yeah, I think osteoarthritis patients are commonly seen by general practitioners where the pain is there. Even in otherwise with normal renal function, we would advocate probably paracetamol as the safest drug, maybe once daily or maximum twice daily. In addition, other modalities which help to relieve pain would be some physiotherapy, quadriceps strengthening exercise, etc., which will actually help. So regular exercises will strengthen the muscles around the joint and that cause significant pain relief. We do use paracetamol on a significant number of patients where long-term pain relief is required.
Okay. So, Dr. Edwin, what do you feel? I mean, you have mentioned about the use of opioids. Maybe we can, if the pain is not relenting with the measures which we use, I think we are a little bit scared to use the opioids. We don't use them so frequently. Do you think they are good options to be tried?
Yes, definitely. It has to be monitored. We have to tell the patient, to educate the patient about its addiction. Use it at very low dose. Choose the right patient who is well educated about the side effects. And in somebody with calciphylaxis or some other very bad neuropathic pain. Many of our diabetics have very bad peripheral neuropathy, severe pain. Probably this is a good option.
Yeah, because pain management is also important, I think. We cannot just tell the patient we can't give you any painkillers, so just keep on suffering from pain. So it's just not practical. So we have to...
Actually, the last 3 years, there have been a lot of articles in all our journals about pain management in CKD. So it's actually opened up new vistas of management, and it's like a patient's pain has to be solved, though we won't be able to solve 100%. So they go to the extent of saying, tell the patient that you won't be able to give a complete relief. But even if you give a 30 to 40% relief, it's a reasonable clinical goal that you can achieve. Opioids, I think we must all start using. Of course, there are a lot of regulations on the use of opioids. How to use it as an outpatient is all a challenge. But there are palliative care clinics, especially in the oncology groups, where morphine is even prescribed as tablet forms. But then all that is regularized in these palliative clinics, and these are being dispensed. Actually, the oncology groups have a lot of palliative work, and they even have an Indian Journal of Palliative Care. In Dr. Georgie's, in Dr. Kashi Ishwaran's next book, I am written a topic on palliative care in CKD, where just reviewed all the literature. And there's so much of literature available on the use of drugs, especially the opioids, in very severe pain.
Yes,
Maybe,
so I think the focus is changing now. Focus is on patient comfort, patient-related outcomes, and palliative care. So the patient says that I'm not scared to die because of kidney failure in the long run, but I'm having pain today. So we can't see the patient suffering, and patient cannot tolerate the pain. So what you said is very apt.
Yeah,
So,
as sir has said, just what I'd like to add, monitoring is very important, because when we give and there's acute deterioration in the function, acute and chronic changes, those same drugs will cause unintended effects. So monitoring, as sir has said, is very important. But we need to really take into account the patient's pain as well, and then go that step forward with adequate caution. Thank you.
yeah. So somebody has again asked in the chat box about, for a normal person, will you give diclofenac, or as a nephrologist, you are scared to use NSAIDs altogether? So Dr. Edwin, what would you say to that?
For a normal
You use
person,
diclofenac.
if there is an indication, definitely one has to use. Somebody has a trauma. So somebody develops an acute arthritis. Somebody has an injury. So definitely NSAID should be used. Which is a group of patients one has to be careful. The elderly, diabetics, hypertensives, people who are on ACE inhibitors, patients with cardiac failure. In whomever you think the eGFR is likely to be low, there is likely to be afferent arteriolar hylinosis. So this is a group of patients where NSAIDs can be troublesome. In this particular group of patients, if you're forced to use an NSAID for a particular reason, we can go ahead, alert the patient that in case you develop any edema or oliguria, get back to us. Or I think it would be safe to prescribe for about 2 or 3 days. However, as Georgie mentioned, that even a single dose can precipitate an AKI in a patient who is susceptible to develop AKI. In somebody who's got very bad afferent arteriolar hylinosis, afferent arteriolar sclerosis, and diabetics especially. Or when somebody like a nephrotic syndrome who already has effective arterial blood volume that's low, NSAIDs could definitely be troublesome. So it is not a strict contraindication. One has to look at the indication to use it. And if there is an indication, it has to be used for short periods of time, educating the patient about the side effects and asking us to report to us if they notice one of these side effects.
And we should be aware of the drug interactions, Edwin. Yeah, because
Yes.
when they are giving, especially ACE inhibitors.
ACE inhibitors.
And then people who are, people who have cirrhosis, some underlying liver damage,
Correct.
or hypercalcemia. In nephrology, people who are on CNIs. So I think these interactions should be, we should be aware of that before we prescribe. And of course, avoid in all high-risk groups.
Absolutely, absolutely. So I think that brings us to the end of this panel discussion. And it was really a pleasure interacting with the physician community, with right from IME, API, RSSDI, ACP, and the nephrology community. The only point what we have to work on is how to implement what we are discussing in these programs. So somehow the nephrologists keep on seeing patients in end-stage kidney disease, and it's very common to see patients coming with a creatinine of 6 or 7, being diabetics and hypertensives for 10 years and never having a value of creatinine or a urine albumin with them. So this scenario should change, because as I was telling, we cannot manage the huge burden of end-stage kidney disease. It's just not possible. So we have to prevent the CKD in the earlier stages, and the people on this community, they are already very well informed. I mean, the physicians are aware of this, but how to take this to the grassroots level so that every prescription which comes from a GP also has those 10 commandments and a urine protein and a GFR written on it. If not GFR, at least a creatinine written on it. These things somehow are not happening. So I think we have to collaborate and work as a team, because nephrologists are busy managing end-stage kidney disease, and I think that's not the right approach. We have to focus on preventive medications, preventive nephrology as well. So I think that's the whole purpose, and it was a pleasure having all the eminent panelists here. And I thank all of you, each one of you from the bottom of my heart. And Dr. Narayan Prasad, thanks to you as Secretary of ISN, Dr. Edwin, Dr. Anuradha, Dr. Udaylal, Dr. Srirang, Dr. Rakesh, Dr. Bhalla, Dr. Khanna, Dr. Abraham, all of them joined, and many of them stayed till the end of the program. So really, thank you. And I think we need more suggestions from nephrologists as well as physicians to now stop discussing and get it done. So how do we go about it? So thank you.
Just to announce, Dr. Manisha, just we have already made a contract or signed an agreement with AstraZeneca 2 days before. We have the data of the 2 lakh patients screening with urinary protein creatinine ratio and serum creatinine. And so we are likely to get the data from this screening in next 1.5 to 2 years. So that is already an agreement between us and AstraZeneca. And they might be approaching to different journal members, different physicians, and the patients coming to the physician's clinic, we will be catching them. So that is the new development. So that just I wanted to inform you.
That's a very nice initiative by ISN, Dr. Narayan. Excellent initiative. I think it's the need of the hour.
The only problem is there that whenever you have any kind of required for the publication purpose, even the serum creatinine is not well standardized. They ask for from where the serum creatinine has been done, whether there was in the laboratory where it has been done, has any reference to reach up to the IDMSA methods or any approved laboratory, that kind of things. So that is all the problems that everyone might be feeling, those who are involved in
absolutely, sir. It's easier said than done, because even albuminuria also, like single report may not be of much value. And then you have to see whether it's persistent. So it's not that easy, even screening for CKD. But only thing what I'm saying is that at least even if one report is there and if it's abnormal, as of now, we are not seeing any reports, sir. Neither creatinine nor, I mean, it's a very common scenario. So I think the initiative by ISN is, I think, the need of the hour. It's a very good initiative.
Thank you very much.
Yeah, thank you, Dr. Narayan. Thank you. So any other comments from anybody else, or shall we close the panel, call it a day today? In fact, it's now 9:50. So I think, Dr. Uday, you want to say something? Dr. Sonal, anything, any parting words from you?
No, I think Dr. Manisha is an excellent program, and I think we should try to make these as a series. I think because this will go a long way in helping all practicing doctors, right from physicians to general practitioners, and various other topics like, diabetes with nephropathy, etc. Those kind of topics, I think are very practical and which will go a long way in helping the daily clinical practitioner. So just one thought, and I think it's a great thing. Try to make it a series. I think it will be a great initiative.
So Dr. Uday, thank you for those comments. Dr. Abkari also pointed out, I mean, we can have those modules, maybe with pre-test, post-test, small modules, short modules for practicing physicians, because that's what the message needs to go across. Like the Diabetic Society has those training classes, which are very well attended and very useful. Because, I mean, they should know what to do, what not to do, do's and don'ts, maybe 10 steps, something like that, so that everybody at least follows those steps. If not the molecular aspects, pathophysiology and all, that's for the academicians and researchers to discuss. But we have a strong workforce. We need a strong workforce. Maybe now we'll be bombarded with Ayush workforce as well. So we have to, I mean, employ all of them in a constructive manner, so that we need all the help we can get, because the numbers are too few. Physicians and nephrologists combined also, I think we won't be able to control the tide of CKD otherwise. Girish, sir. So you have logged in as Dr. Umesh Khanna, sir. Yes, sir.
It was a wonderful initiative, wonderfully conducted program, Dr. Manisha. I must congratulate you and all the other our invited speakers. It was very informative. So I am sure the physicians who have been participating have been definitely been informed and bit wiser after this interaction. So I congratulate all the panel members and Manisha and the other members for conducting this webinar. Thank you, Manish.
Thank you very much.
Congratulations. and,
Thank you. Thank you. Thank you, ma'am. Thank you. Any words, any, I mean, suggestions?
you,
from
Manisha.
your
Thank
side,
you.
Dr. Anuradha?
Thank you.
Oh, Manisha, I think
Yeah.
as everybody has said, an excellent meeting. I think very informative. Only thing is, probably, we should learn to stick to time.
True, that's very true. That's very true. So I think the discussions can be more crystallized, I guess, or maybe questions could be made shorter.
Yeah.
Thank you. Or maybe the topics could be
From-
lesser. I think we could
From
keep lesser topics.
breakfast, from a evening tea to it has become a dinner. meeting.
Absolutely. Absolutely.
No, but you have planned it like half an hour for each talk.
Yeah,
15
I know.
minutes talk and 15 minutes discussion. And I think that we should have,
Yeah, I think
in
we can-
any meeting, time management is also very, very important.
Absolutely, madam. Absolutely.
Okay.
So I think
Good
we
night,
should keep
everybody.
lesser topics and have it broken into more sessions, I guess. So if you have too many panel members with lots of ideas, again, it becomes a problem. So that's very true.
No, but if the answers are to the question, just not, again, not like a talk, but just short and crisp answers, you could have, I mean, maybe, that is important because in any meeting, I think time, we all should learn to keep to time.
Absolutely, madam. Absolutely.
Yeah.
Yeah. Sometimes it becomes a bit delicate or difficult. That's the problem. Yeah. Okay.
Edwin, good night.
Good night.
Good night.
Good night, all.
Good night, Srirang. Good night, Uday.
Thank you.
Good
Thank
night,
you.
ma'am.
Uday.
Good night, Georgie, and
Georgie said good night. Thank
Yeah,
you.
good
Thank you,
night.
Dr. Balla. Good night. Thank you. Thank you very much.
Good night, madam.
Good night, Balla. Good night. Yeah. Okay.
Camera off.